Good afternoon, everyone. Welcome to the webinar by Department of Health and Family Welfare, Government of Odisha on COVID-19. In the series of the webinars, we have some very interesting cases and a most needed topic today, which is about the radiology in COVID-19. Initially when we started detecting the problem, RT-PCR test was the only test which was taken the gold standard for confirming the disease, and for a case definition, the RT-PCR positivity was must. But besides, then rapid antigen test came, and it was seen that series of findings in X-ray and in CT scan were found in patients of COVID-19, which were further classified into codad up to 26, and the different radiological and the CT scan findings were classical, basing on which the clinical suspicion was very stronger, and the test was repeated in few patients whom it came initially negative. So with this background, we thought that a topic on the radiology in COVID-19 with the X-ray findings and CT scan findings will be very befitting for all those who are dealing with patients. And today, none other than Professor Prashant Raghav Mohapatra, the head of pulmonary medicine from AIIMS Bhubaneswar, will be speaking that, so that not only you will get the radiological picture, you'll also get the clinical correlation, and he'll give a clear message as to how to interpret that finding, whether they're important prognostically, they're important for monitoring, or they're important, have any importance for the diagnosis of the disease, how to correlate that in a patient who is a mild, moderate, or severe patient, and what is taken as a classical sign in an X-ray or a CT scan of a COVID-19 patient. So I thank Dr. Mohapatra for agreeing to our invitation. Last time he was there as a panelist for some time and he interacted, and I have requested him today that he'll spend some quality time, because we have very interesting 3 case presentations from Ashwini, from IMS and from KIMS. Dr. Sampath Das, a known healer of COVID-19, will be presenting a case from Ashwini. He has presented before you earlier, and not only he is a thorough clinician, he is a good academician, and the academic clinical correlation along with the case presentation will be definitely informative, I'm sure. Followed by Dr. Shakti Vedanta Mishra from IMS and Som Hospital, who is MD anesthesia and a very active critical care specialist at the Department of Anesthesia and the COVID hospital at IMS and Som. And the most important message we want to give, that the different centers, the Ashwini, the Aditya Ashwini, the Som, the KIMS, and different centers throughout have different patients, and those who are following them up, give them the classical scenario which will boost up your immunity, and you can take up them very confidently. In your practice also, you can know the use of the different drugs, different antibiotic coverage, when to use oxygen, when to use steroid, when to use plasma, when to use antivirals, and the message will go clear. Last, we have kept a presentation from KIMS, Dr. Ashok Badmali, who is again MD anesthesia, is in charge of the critical care ICU and COVID ICU at KIMS, will be presenting case, and this case will be correlated with the clinical findings as well as the management, and they'll give you a message. Besides, we have a very learned panel today. Professor Niveta Pani, who is with us all the time and at SCB Medical College in charge of training, she'll be there. She's already attached to the group, and from her place, because of this scare, all are getting connected and all are co-hosts today. As all of you see, Dr. M.R. Patnaik is in a right now is in a video conferencing, and he'll join us very soon in a half an hour, 1 hour time from this center only. And Professor Mahapatra is already there, as you have seen him. And we have requested Dr. Shamir Sahu, the Chief of Critical Care Consultant, the Care Hospital, who has been a faculty throughout and instrumental in managing very sick COVID patients in Odisha at present. So we have very efficient panel. We have very active, dynamic presenters. And to start the whole process, I invite our honorable additional DMT sir, Professor Brajakishore Das. We have taken the go ahead from our DMT sir, Professor CBK Mohanty, who is there always inspiring you. Last time he came and he requested that the senior doctors should come forward to render services in different COVID hospitals, so that the message will go that the people have got their best, even for them whom we are unable to shave. And Professor Das is with us to start the motion. And without much delay, I'll request Professor Brajakishore Das, our additional DMT chair, to give a word of introduction and start the whole process.
Uh, good afternoon, everyone. First of all, I am thankful to Professor Jan Panda, my immediate senior and an eminent clinician in his own right, in that he has invited me to be part of this academic thing. We have got as rightly pointed out, we have got a panel of experts, starting from Prashant Mahapatra from AIMS to Samir Sahu of CARE. All persons are the stalwarts. Yeah, Sampad Das. And what we will be doing, as last time we have discussed, that because of these case discussions, everybody will be sharing their knowledge, and by sharing, all of us will be learning new things. And I must congratulate Jayan Bhai, Professor Jayan Panda, that for his immense effort in organizing this type of things every week, unfailingly, and reminding everyone that you have got a presentation, you have to do this thing, and people are. It has now become a habit that people are waiting for this weekly inputs. If you can see that starting from initial days when there was very less in the number of participants, apart from the speakers, now we are getting a lot number of participants, and rightly so, because nowadays, because we are having COVID hospitals in each districts, where the people actually need, apart from the theoretical knowledge, they need to share the practical experiences. So this is a good step, I believe, managed by Professor Panda and supported by everyone. So let us listen to the case presentations and start the process of this webinar. Thank you all.
Thank you, Professor B.K. Das. Thank you for that introduction. We have all support from our DMT chair and the whole team of medical education training. So the capacity building should not be less in any means. That is the purpose, so that any new thing that comes, it may be a radiological finding, it may be a drug, it may be a investigation that can be thoroughly highlighted, because best of the academicians are involved in the Department of Health and Family Welfare Capacity Building Program. Thanks, Professor Das, for that nice introductory note. With that, I'll just give you a country and the world scenario. So I'll request our team to share just 2-3 slides of mine, where so the whole world is burning with COVID, and to, to the present time, we have around 2 crore 77 lakh patients in the world, out of which around 9 lakh people have lost their life. But the good news is that around 2 crore people, it's approaching 2 crore, now 1 crore 98 lakhs have already recovered. So out of this patient, we have around 77 lakhs active cases in the world, but almost 2 crore people have recovered. Unfortunately, around 9 lakh people have died, and 2 crore 77 lakh is the recent number. The country has to date around 43 lakh 74,000 patients, approaching 44 lakhs, and around 74,000 deaths, 73,953. But the good news, 33 lakhs out of this 44, 33 lakhs 98,000 patients have already recovered. So you can tell that out of 44, 34 have recovered. So around 10 lakh patients are active in the country, that's in India. And in our state, to date, we have 1 lakh 35,000 patients with death touching 580. And good news for us, yesterday our very beloved uh, Chief Minister Ji have congratulated all of us because the recovery rate has crossed 1 lakh. The day the cases crossed 1 lakh around 10 days before in the end of August, we were all scared, but now recovery rate has crossed 1 lakh. So with this, I thank the whole panel for giving their time. I thank the guest presenters who have joined, and I thank all the audience who have already joined and joining. I expect similar huge crowd today also. I know the cases are increasing, the work is increasing, all are preoccupied, but still we have good participation, good number of questions, and good presenters throughout, and we'll continue this trend as per the demands for all of you. Thank you for keeping confidence in us and coming week after week for learning and capacity building. So with this, we present you Professor Prashant Raghav Mahapatra, who is a very senior consultant in pulmonary medicine. He is part of the tuberculosis uh, vaccine trial at AIMS, and he is a fellow of Indian College of Physician and has been a part of the COVID management at the national and the state level. So Professor Mahapatra is a thorough academician, and along with COVID, now he is also managing non-COVID, starting from the asthma, COPD to the carcinoma lung patients in their very much attended AIMS Bhubaneswar. And he has been always there with us whenever there is some academic cause. He has many publications to his credit and many awards to the credit. I'm not going details of that. With this background, Professor Mahapatra will be speaking about the radiology in COVID-19. He'll cover the X-ray and the CT scan with correlation with the clinical importance as well as the different stages, mild, moderate, severe, and the management protocols. So we present you Professor Prashant Raghav Mahapatra from AIMS Bhubaneswar as the keynote presenter. Professor Mahapatra. Yeah, Professor Prashant Raghav Mahapatra. Sir, you can start. You can share your slide set.
No, not sharing. How to share?
There is a green button in the baseline written share screen. Just to see. You are a co-host, so there will be no problem. There is a button called share screen. Yeah.
You share now?
Share screen.
Is working?
So you have to select. You first open the slide in your desktop or laptop.
Yes.
You
No, I have opened two things, and the desktop I am here. This is now open.
So you go to share screen, which is below this one, share screen.
There is a green basket is there.
Green colored share screen. There is an arrow facing upwards.
Yes, okay.
You click that.
This one. It's okay.
Yeah. You click that. Then your desktop will be shared. And you have to select this slide.
Host disabled लिखा हुआ.
Prashant.
No, the other one. I have opened two screens.
The screen in which you are connected. You see.
No, that not that screen, or the other screen.
Then you close that.
Acha, then you close it.
That which you want to show now, please open that.
Okay.
There actually you are connected from two links.
Yeah.
Other link is a co-host. Oh.
Sorry.
No problem. Technical snacks that keep happening. Actually, your other ID was host.
Host disabled.
No, just wait. Rajiv.
Raghav,
Huh?
have you opened your slide? Which one you want to show?
Yeah. But host has disabled participant screen sharing.
Now go to the share.
No, the sharing, but share screen host. Yeah, yes.
Please go to the
Yes,
share
yes.
screen. Then you click it. Yeah.
It's come.
It has come.
Good afternoon, everybody. So I'm thankful to the whole team for giving me the opportunity to be with you. And so I am discussing as a clinician, for the clinician, discussing clinical COVID-19 radiology for the clinician. So I have been given assignment as a nodal clinical expert for the resource person at the most effective state, and particularly in Odisha, by Government of India. Also, I am deputed as a central team member for the review of public health measures for COVID-19, again by Government of India at different date. So the photographs I have taken, some of my own institution of department, and some of are from the academic journals, peer-reviewed journals for academic interest. So this is one of the. This is visible. Is it visible?
Yes, it's visible, Dr. Prashant.
Yeah. So our recent experience. So I'm just saying, but we have seen 2 weeks before what has happened. One patient who's come with ILI, influenza-like illness, and admitted with suspected COVID, but RT-PCR come as a negative. So that's why he shifted to our respiratory ward. But when I taken round, I have some suspicion. So it doesn't look to look at the X-ray, it looks normal, but to me it doesn't look to me it doesn't look normal. So I have found some sort of opacity, tiny opacity, bilateral. So I send it to, let's do a HRCT. So let's see the HRCT. This is a full HRCT view. You look at some lines, some septal thickening, and some ground glass opacity, peripheral subpleural ground glass opacity, and this both the sides and bilateral multilobar infiltrations. So I saw that it's COVID. So I shifted to again to the separate ward we have, where which clinically suspect, but RT-PCR not proven. We cannot keep it together. Let's see another experience again after 3-4 days. After another 31-year female come with similar symptom, again more of symptoms, again RT-PCR negative. So because RT-PCR negative, shifted to again pulmonary medicine ward. Similar situation occur. So this is more it's more prominent. You can see, everybody can see bilaterals, multiple shadow, non-homogeneous shadow. So that it's now it's just a full up COVID picture. This is for X-ray CT or 1 day difference, both the cases. So with this experience, what I can say that we have peripheral distribution of bilateral, multifocal, lower lung involvement, particularly in context of COVID pandemic and typical clinical presentation of COVID. The CT picture, particularly viral pneumonia, we suspect COVID-19 strongly, even if their RT-PCR is negative. In these cases, what we should do? We should do repeat testing and get the diagnosis as soon as possible. And if condition deteriorate, we should treat as a COVID patient rather than even if, because we know the inherent nature of the test, we may not get 70%, around 70% cases we get. Again, timing of the testing is more important. After 7-8 days, may be negative. So we have. So coming to the typical finding, I do not have a typical. I just have some common features. Then I'll go to the individual presentation. So it is mostly present as a multifocal bilateral ground gas opacity. It is usually peripheral and basal distribution. That means lower zone is more involved, and there may not be sharp demarcation. There will be vascular thickening, mostly rounded, quasi-paving opacity, and maybe more dense consolidation, or we may see a reverse halo or a spider web segment. But at some atypical finding are peribronchovascular pictures, and may get lymphadenopathy, not common, may get cavitation, may get tree invert like which is a pictures of bronchiolitis, or may pleural thickening. Even if pleural effusion is not a common, but we have seen many cases. So let us see the stages of CT changes. So 4 stages of CT has been described. Early stage usually first 4 days. Normal CT, we may get a normal CT and may get ground gas opacity if do CT within first few days. So if once it progresses, it ground gas opacity usually increases and quasi-paving appearance. I will discuss quasi-paving ground gas opacity later on. And peak stage, if you do a CT scan, it's 9 to 13 days, around 10 days to 11 days. So we may get a dense consolidation. And after that, it automatically get up, try to adjust depending on the disease kind of extent of the disease. And it's become some fiber strip, some streaks, lines bilaterally appears and gradually tend to disappear, may not disappear fully. So early stage we discuss. So first 4 days ground gas opacity, quasi-paving, and progressive 5 to 8 days we discuss as a more of increase of those shadow, and peak stage around 10 to 13 days more of consolidation. And after that, after 2 weeks, remember after 2 weeks there is a gradual resolution of the shadow. Patient may improve the condition. So let us take a few basic things. So it's not related to COVID. Just give you an idea. So this is it's a reticular shadow. So you see fine reticulation, right apparent side, fine reticulation shadow. It's totally different from this left upper shadow. So this is nodular. If you look at right lower, it's a reticulonodular. It's a mixture of both upper. And if you look at the ground glass, so what is a ground glass? So ground glass opacity is nothing but increase, as picture, increase haziness, increase opacity, not obscuring the bronchovascular bundle, bronchovascular markings. So it's not a COVID situation. I'm just giving. Previously, before COVID, we said that hypercystic pneumonitis, means pneumocystis pneumonia. So we may get hypercystic, we get ground glass opacity. But this is due to particularly partial filling of the air spaces due to inflammation, viral inflammatory materials, and there is intralubular interstitial thickening, and there may be partial collapse of alveoli along with the inflammatory fluid. And there is but one thing is, remember, this is a preservation of the bronchial and vascular marking. It doesn't obscure. So that means you can demarcate the bronchovascular marking. So lung volume is preserved. And let us come to the classical COVID. This is a classical COVID. It's a ground glass opacity. Patchy areas go pure ground glass opacity. So now you can see pure ground glass opacity. I will show this side of this picture in another context once again. This is a this is a ground glass opacity. This is not COVID. This ground glass is not COVID. I just had to compare it, and this is consolidation. Then what is the difference between consolidation and ground glass opacity? Ground glass opacity is increased opacity, increased haziness, but consolidation is it's more than that. Again, air bronchogram is intact. In particularly consolidation, it's a dense opacity, and it's a ground glass is a faint opacity. So that means consolidation is a solidification of lung because of heavy inflammatory exudate, particularly seen in lobar pneumonia, particularly in pneumococcal pneumonia. Lung behaves as a solid material, so it's at a phase of consolidation, but airway remain patent. So that's why airway bronchogram is seen. So this is difference between ground glass opacity and consolidation. Let us see another patient. Look at, to me, like X-ray is absolutely normal. That it is taken 1 hour apart. It is taken from some other book. Look, we are missing a shadow by CT. That's again patchy peripheral ground glass opacity is there. So that could have missed if we do not have a CT. The another diffuse bilateral confluent predominantly linear ground glass opacity. So this and particularly arrows, you can just a stigma and bilateral ground glass opacity. Here is a rounded opacity, and these are also again ground glass opacity, patchy ground glass opacity. So CT image also so patchy ground glass opacity, very faint opacity. Here it's it's not that much clear. It was seen earlier, but lower picture are more of opacity. So you cannot have a distribution between the faint ground glass or is more of consolidation nature, and it is taken 5 days after. 5 days after, it shows that its shadow has been more whitened. That means more dense. That means inflammatory fluid has accumulated in alveoli more than what it was earlier stage. Let us see this again. Some pictures. So again, ground glass opacity. And apex to the basal segment, bilateral subpleural band-like opacity. You can see that some band opacity, faint opacity is seen. I mean, not exactly, you cannot demarcate, but you faint ground glass opacity. And this is classical of viral pneumonia. Remember, let us come to some basic slides. So what we are going to discuss. We are interested for two things. One is, you see, this is the interstitial network of the supporting lung. So this is bronchovascular bundle, and this is intralobular interstitium, and this is one lobule. This is interlobular septum. So here there is interstitium is involved, more of intralobular interstitium is involved, and particularly this disease of the pneumonia is a disease of the alveoli. So we may get a peribronchovascular, centrilobular that present as a T involved, intralobular may present as a ground glass opacity, interlobular may present as a crazy paving we'll discuss, and some subpleural shadow may have some opacity with subpleural demarcation. So let us again, like chest X-ray, let us discuss. This is peribronchovascular. Remember, sarcoidosis is a bronchovascular disease. But bronchovascular, this is a classical shadows of sarcoidosis. This is not COVID. The left upper lobe, it's an interlobular center. This is more of it is an interstitial disease. Although it is interlobular pattern is there. Here it is intralobular. That means very minute. And it is the last one is subpleural. Subpleural shadow means it may mimic, but here it is one-sided, not bilateral. So it is not. These pictures are not from COVID patient. This is for the educational purpose to how we can demarcate, differentiate between all the pictures. This is what we are going to discuss, the interlobular shadow. So what is interstitial septal thickening? A patient of 92 years may admitted to the emergency with present picture of COVID, and CT shows interlobular septal thickening, predominantly upper zone. You look at this interlobular septal thickening. I'll show you intralobular. So consolidation area, interlobular septal thickening, seen as both lungs. So this is so septums are very clearly, but interlobular you may not demarcate as the interlobular. So interlobular is something different. So mixture of ground glass and consolidation, absence of there is no pleural effusion, and this is a confirmed case of this is again ground glass opacity in posterior and bilateral shadow. This is again the line of the fissure. So that again you look at. So I'm demarcating one picture from the book. One is SARS-CoV 2003, So that was almost 17 years before. And that is again SARS-CoV, not much of difference. Look, the viral pneumonia are more or less similar, not much of difference. And depending on how progression the stage, behavior of the disease pattern. So not much of difference. It is bilateral, multifocal. So let us see what is another one. Is a halo sign. So this is a nodular opacity. Look at it, like it's a bright sign is coming. The dense center is more dense. So it's a consolidation, central or peripheral distribution. The ground glass halo, which is that means center is more dense. It is halo. So let us see the pattern halo sign. It also seen in, not very common, but seen in also this COVID. Look at the initial cases. The center is dense and periphery is less faint. That is periphery ground glass appearance. Center lobe more of a consolidated, more consolidated. So it is halo sign. But we are more concerned of typical reverse halo sign. Unless I show you halo sign, the reverse halo sign is opposite of that. So that means central hypoechoic shadow, central lucency, and peripheral there is density. So it is known as, otherwise known as atoll sign also called. So crescent, ring, then like ring-like shadow. So this again shows both coronal, sagittal, and axial shadow. That shows that the surrounded by consolidation, and there is halo sign. The halo sign, you can see that this is halo sign. These arrow marks are all halo sign, right? So this is again halo sign, and both picture has a both halo sign, and the picture has a both reverse halo sign. I think it's clearly visible to everybody. So coming to the early stage, we discussed is the ground glass opacity, predominantly distributed peripheral, subpleural area, and quasi-paving. I'll discuss later on quasi-paving. Secondary to intralobular and interlobular septal thickening can be seen in stage, and as the disease advances, the opacification become more. It is becoming more of consolidation and coexist. It can be varying size, varying air program present all the time, and diffuse. That once patient becomes severe, it's more dense, more opacity, more inflammatory fluid get accumulated. It's almost whited out long at times. It has seen areas of ground glass opacity nearly completely resolved, and after some time, once it started resolving, it almost resolved. It is the same. It is resolved, but some shadow remains for weeks, more than weeks. So let us see the serial changes, how it has happened. This is a patient once presentation. Look, maybe some opacity, but not exactly so much abnormality. You cannot say it looks more of soft film. But you look at the day 6, some shadows has appeared on same patient. Again, day 8, some more shadows are appearing. So this is bilateral ground glass opacity. I mean, say the faint shadow. So that is X-ray also, you can set a ground due to and some septal thickening. This you can see some thickening as there and presence of ground glass opacity. Again, another patient, it looks more clear than before. Again, on the day of presentation, there is definitely shadow, bilateral shadow. I can say, you can say, see, these all are shadow more right side than left side. Again, the shadows are more prominent and right side day 4. Again, towards day 7, it is more of diffuse rather than more prominent, concentrated in one area. So diffuse, and after that, we do not have a record of that patient. And coming to the CT also, serial day 0 and presentation, it may be a small ground glass opacity, bronchovascular marking is present, the vascular marking also present. And over the time, what has happened, again, it's again same shadow after day 3, it's becoming more prominent, more means it changes more peripheral consolidation. You may see, say, reverse halo or not. There is some ground glass opacity definitely. So this is again, you look at the lower one D, in particularly compared to C, there is no subpleural region, particularly right lateral side. So here on the picture D, there is subpleural ground glass opacity on D. Again, there's a diffuse reticulation corresponding to CT. That means this is CT, you can say diffuse opacity. Again, peripheral ground, if you look at the middle one, the white arrow, the peripheral ground glass opacity, again, extensive consolidation on right side, extensive consolidation, particularly consolidation. Look at, I'll say this is what this white marking, the particular white is more prominent. I'll discuss later on. So again, let us see the more serial CT. Day 3, I already discussed. Day 7, it's become more prominent. And look at after 2 weeks, it started that actually this ground glass shadow decreases and more of a prominent lines and septal thickening, some streaks remain. And this day 18, again slightly less than that, and towards the end of, I said towards 4 weeks, end of 4 weeks, it is almost decreased, but not never ground zero. It's some residual shadow remains. What I mean to say, it's more or less similar things. I can say all this, though this again changes, serial changes of the many percent. Look at the ground glass opacity has expanded, plus reticular pattern is already on day 9. Again, it has decreases over the days. If you look at this ACR day 13, these are ACE day 13, and the right and left hand side VDEF are the day 19. If you look at the shadow, there's no definitely it has come down. If you look at this one peripheral shadow, this seed formation interlobular septal taking on day 13, and it has definitely disappearance subpleural curved line, and that has become, the shadow becomes subpleural curved line rather than the dense shadow. So if you look at this, and peripheral ground glass opacity were observed particularly in these arrows are ground glass opacity, and these are the picture of consolidation. This is fissural marking, and some area of the may see, look at the dilated bronchus and particularly bronchiectasis they may see. This is what I mean to say. Lot we're crazy of discussing of crazy paving. So this is air bronchogram is seen. What is crazy paving? If you remember two things, if you superimpose reticular shadow, that means in septal thickening, interlobular septal thickening on ground glass shadow, you just see a crazy paving. It will crazy paving was classical for pulmonary alveolar proteinosis. So, but not exactly seen in COVID, but definitely it is more of opacification along with the reticular shadow. So let us see what is ground glass opacity rules about the crazy paving. So air bronchogram seen, these are more crazy paving. Again, these are our vascular marking is seen. So let us, what is crazy paving? Crazy paving, whatever, this is something, a floor. It's a paving. So look at this one. This is not COVID. So this is to show what is crazy paving. This is not COVID. This is crazy paving. How we are discussing crazy paving. This ground glass opacity with superimposed reticulation. This is a classical of problem. So this is not COVID, and this is maybe COVID, but this is the so this is again PHE crazy paving. This is not the left side, right side is not COVID. Let us see the COVID picture. So confluent PHE ground glass opacity, pronounced peripheral and interlobular septal thickening, that is in the right upper lobe and right lower lobe respective. These are all crazy paving. I think this is now it's very clear what is crazy paving. So this is, I would say, classical of crazy paving. It's a sputter. It's pulmonary alveolar proteinosis. We come across rarely. Here also we get 2 cases of PA, and we did total bronch lavage, whole lung lavage. And this is again what I would say, multiple linear shadows seen in bilateral shadow. So once it progresses, these linear shadows are seen was clearly standard, clear than most. As the days gone passes, it become more clear and predominantly distributed in peripheral shadow. So again, same fibrous streak lesion noted in right lower lobe. So becoming right, it's more become prominent as the days progresses. And look at the another one. I have shown the vascular prominence. These are vascular prominences. These are also due to COVID. It's not in other diseases. So look at the same city I have shown earlier, showing the ground glass opacity. I'm just same city as showing there's a more of vascular enhancement is seen, even if not even without any contrast. These are the vascular enhancement. It is seen vascular enhancement, how much it is. These are proximal dilated vessels, intralesional dilated vessels. So different level of vessels are dilated, and this is because of COVID. Again, air bronchogram, it is clearly seen in that's like consolidation. Once it has become a denser shadow, more denser than ground glass opacity, air bronchogram is visible, and this is it's a more it's more of consolidation becoming. I mean, patient not in prone position and becoming it's half posterior person are consolidated along with the air bronchogram, and you see both the sides are plurally fusion also seen. And coming to the not very common but tree in bud shadow. Tree in bud shadow usually, I mean, say that I think the picture itself says this is tree and this is bud, left hand side bud. So this is tree in bud, classical of other diseases. Maybe I can say tuberculosis, not bronchial tuberculosis, but this is not a classical of the COVID, but this is a typical picture. Again, tree in bud is more pronounced here. So this is again not COVID. So this is again a focal area of tree in bud appearance. I think now it's, so I'm just giving it for better understanding what is tree in bud. So now it is COVID. So this is, I mean, it's very uncommon, but it is seen in COVID. Look at this one, middle one. I mean, left posteriorly lower zone. That means that's tree in bud appearance. Here also in tree in bud appearance. This is tree, this is bud. So tree in bud appearance, but it's not very common. So coming to the indication of the CT. So CT is done in particularly patient with dyspnea. If you said CT indication, I can say moderate and severe patient to be done CT, or moderate severe patient deteriorating with pre-existing lung disease and all risk factors, and there is elevated inflammatory marker. We have already been discussed what are the inflammatory marker. So what is going to see typical ground glass opacity with or without consolidation? Lung region, particularly subpleural region close to the pleural surface area, close to the pleural surface, may including fissure, maybe subpleural sparing may be allowed in some places bilateral multifocal distribution, and ground glass opacity with KG paving I discussed. So if you look at this pattern, so look at ground glass, bilateral, posterior distribution, multilobar, peripheral. So these 4-5 signs are mostly in 80% cases. Ground glass, bilateral, ground glass opacity with posterior location, predilection of the more posterior location, multilobar involvement, and peripheral distribution are classical. Some percent go to. So let us see this one correlation. Look at if CT is becoming more prominent, more chance to get a RT-PCR positive. These are on red color. If CT is not very, we may not get RT-PCR positive. Again, it depends on which day we are doing. I was thinking to discuss CORADs. So I have now, towards end, I discussed not to move our body. It's a task of the radiologist, not the clinician. But why? But I can say definitely CORAD 5 and 6 are definitely suggestive of typical of COVID. So CORAD 1 is highly unlikely. CORAD 2 is again unlikely. 3 is equivocal. So 1 to 5, middle is 3 is equivocal. 4 and 5 are suspicious of COVID. This much you can say. We also do a visual analysis. 0 is no pain, 5 is more pain, maximum pain. So mid category is something like 3. So if you have a visual analysis scale, so this comes to the, so the radiology. So there may be, I can say this, you look at the radiology. I do not want to this, if less than 8 is mild and more than 15 is severe. But I just say that it is better to look at the all and CT, I mean, so all the areas of CT at a glance. So rather than we count it and taking a scoring system, it's a radiology percent for this, for clinician, I don't think much. So let us see the CORADs. So CORADs 0, I mean 1 is doesn't look like anything other than some vascular artifacts. The CORAD low, that's very small shadow. CORAD 3 also, you may not get some ground glass opacity, not much. And CORAD 4 is definitely ground glass opacity. CORAD 5 is bilateral multifocal ground glass opacity. So that means the probability of getting COVID is very high, in particularly CORAD 5. So that again, so this is again atypical features. So what I am to say that it's not always peripheral located, not always subpleural, not always posteriorly. At times also gets a atypical picture. This is one of the atypical picture of COVID that has come from the RSNA. I got it. Same picture. It's a bigger form. So segmental, subsegmental vessels enlargement is again, I have shown it earlier also. Look at this picture. This vessel enlargement is there. This orange vessel. So multiple ground glass opacity with parenchymal involvement is there. So again, similar picture. So same thing and nothing much. So how these things are becoming more prominent. So this is typical air bronchogram sign, particularly this is air bronchogram, black air bronchogram. Here also air bronchogram is sign. So there is some sort of bronchitis sign, I can say, that better not to. So that is more of ground glass opacity, and ground glass opacity is again decreasing towards day 12. So again, we count day 1 is a day of presentation. So not we do not know when the disease starts. We know the disease may start 2 days before the clinical presentation. So again, these are also same thing. I'm just repeating different level effects. So multifocal ground glass opacity, mixed consolidation, and particularly peripheral area. So this is again same similar picture. So I want to show this vascular enhancement here. Vascular enhancement. So it is classical. So let us come towards end of my presentation. So this is if you get a sign, some symptom, mild, do not go for a CT scan. Definitely moderate to severe, please do a CT scan. So you can, if available. So X-ray is a must. So if a typical COVID, then treat a suspicious case. Even if COVID negative, I mean, so we need to treat if other clinical, particularly in time of pandemic, anybody coming with symptoms of COVID, it has to be COVID unless otherwise ruled out. And we have to rule out with other diagnosis. Just because you don't get a PCR negative, and we cannot say, although PCR is a gold standard. So this is the say. So coming to typical take-home message. So I'm again discussing. So let us say the ground glass opacity, particularly peripheral, subpleural involvement of the multilobe and predilection of the lower lobes posterior segment. So this posterior area is suggestive of COVID pneumonia, and particularly ground glass opacity may have focal consolidation, may have intraocular reticulation, may be looking at a quasi-paping appearance, may have linear consolidation, or may have a halo sign or reverse halo sign. That's atypical sound finding may be seen, very unlikely, but it is isolated one lobe. Discrete only, just you find that only tree in bird, nothing else. So this is again cavitation is very unlikely seen in COVID, but this is not applicable for us. This patient with previous cavity tuberculosis may come up to COVID also. So this can be seen in patient with TB cavity. Doesn't mean that they will not be infected with COVID. So pleural effusion may be seen in some particularly. It's may not be always peripheral distribution. And coming to the some 3 or 4 salient questions. When do a CT scan? What is the best time? The best time is if you can do them 5 day to 7 day from the onset of symptoms. So this is the best time I can say. So and typical present. Can CT be normal if patient is recovered from illness? Not immediately. It may take 8 weeks to 6 to 8 weeks to resolve some symptoms. Again, it depends on what is the extent of involvement of the long parenchyma. That is more important. Then do all the patients with long involvement develop post-infective lung fibrosis or progression of the lung disease? So certainly no. Again, it depends on the existing lung abnormality, depending on degree of fibrosis, depending on the severe infection, and depending on the how long disease is prolonged. You know, any inflammation is, if not treated properly, it is healed with fibrosis. If do not heal in particularly 6 to 8 days, definitely unlikely to heal much. It may improve, but not much. So can you predict the nature of progression of CT chest? The answer is definitely no. But CT can be a guide to assess the patient along with the clinical features. If you say that CT is more confluent bilateral shadow, 1, 2, 3 doctors are there, this CT is very bad, but definitely they are on 8 to 9 liter of long oxygen. So their CT is not as it's not. So if they progress so much of involvement and they are not improving oxygen with oxygen, so time to we have to keep ventilator ready if they are not improving. So can we predict the cytokine storm with CT chest? The answer is no. Cytokine storm is a different entity, so not related to CT scan. So is thorax is a game changer? The answer is no. RT-PCR is a gold standard. If negative, in particularly in the scenario of this pandemic, ongoing pandemic, ever increasing pandemic, only in moderate to severe cases we need to do HRCT. If I'm not getting diagnosis, it is more important. We have got many patients who do not get a COVID negative. Either they present late or after 10 days when no virus is found in the COVID test, or only CT findings are there. Then who is CT? HRCT or CCT? The answer is up to the radiologist. And if you look at only the parenchyma, HRCT can be better. If you are thinking for the D-dimer has raised, there is a particular, you are thinking pulmonary embolism, I believe CT angiography, CCT is a need of the hour, although it may not rule out everything. That case, then coming to the next question, pulmonary thrombus can be, not all cases can be diagnosed with, because all third order division of pulmonary artery, but which are most commonly may not get all the CT scan, may not be very seen unless you do angiogram. And atelectic segment, particularly predominantly interstitial mixed pattern, highly likelihood of thrombotic phenomena. So D-dimer may be a better guide, serial D-dimer, or the patient has to be kept anticoagulant, doctor, and that is already discussed in clinic, clinical scenario. With this, I think I complete this my finding.
Thank you, Professor Raghav Mahapatra. It was a complete presentation on the topic. I just cannot think of a pulmonologist doing so good in radiology. I know that pulmonologists, they have their radiology training simultaneously, because when we are undergraduates and postgraduates, most of the radiological teaching were from pulmonary medicine only. But in COVID, which is a relatively recent topic, Professor Mahapatra has done an in-depth work of all the findings, giving their basic of generation of those findings in the longs. He has also answered all the questions which are supposed to be asked. Questions have started coming, but I think whatever you will think of and ask, Dr. Mahapatra has already put, and he has put the answers as well. So thank you, sir. It was a very nice disposition, and we have become wiser. I'm sure our audience, our COVID hospital doctors, those who wanted a good message from this topic, are all happy. And along with this, those who will watch it in the YouTube will also get the message off and on. And I request you to please stay back. We have interesting cases.
I'm here. No.
Yes, sir. We'll take up the cases.
Thank you.
And Dr. Shamir Sahu is there, Dr. Pani is there, Dr. Patnaik sir will join soon here, and we'll move on to cases. Thank you again, Professor Prashant, for a nice presentation and a nice preparation. So with this, we'll move on. We have 3 interesting cases, and in a hour's time, we should be able to complete all 3 presenter. I suppose they have multiple cases also. And to start with, Dr. Shampad, who is a asset during this pandemic time, not only in managing cases, but correlating that clinically, and has done a good work in our webinars earlier. I thank him for his dedication, for his academics, and we present you Dr. Shampad Das, in charge COVID Hospital, Ashwini, Cuttack, for a case presentation. Shampad.
First of all, thank you, Jan sir, for inviting me again to present a case. So before starting this case, this is just the answer, the question which actually the patient's son actually asked to his father, and he conveyed the same question to me, that will my mother return or will not come back like my grandparents. So the fact is that the patient's father and the patient's father-in-law both have expired within a span of 6 days, after which the patient was actually being brought to our hospital. So this is what the questions which we will be answering to that 6-year child, that whether are we possible, or means is it possible, feasible or not. So let's start with the case. This is actually a 41-year female who presented to Ashwini COVID Hospital on 28 it's around evening time, with complaints of fever which was going on since last 7 days. It was a very high grade fever she used to complain of, because the history which we took was from his husband. So it was a fever of around 102. There was a cough which was simply dry cough without any expectoration, and the breathing difficulty was since last 3 days, which has increased since over the last 1 day. So for the above complaint, the patient has tested to be COVID positive at a center outside and was referred here because of the increase in the breathing, because of increase in the breathlessness, right? So on presentation, when the patient came to us, she was conscious but severely tachypneic, means she was not able to complete a single sentence also. So patients who are unable to talk even in one sentence also, that means their respiratory reserve is very poor. So this is a clinical indication which can give you a data that how severe they are. So you just simply ask them that how are you feeling? They will not be able to express anything. They can just tell you something in sentences. The pulse rate was 120 per minute. The blood pressure was 90 by 60 millimeter of mercury. The respiratory rate was 38 per minute. The saturation was 74% in room air. So this is what we got that case. And the saturation means immediately we have admitted to the ICU, because if we clinically look into this case, I'll be telling that it is a severe case. Why so? I'll be explaining in the next slide. So we have put an oxygen with a high flow reservoir bag, and the saturation still hovers at around 84%. Even with oxygen also, the patient actually had continued to have severe tachypnea. The ABG was immediately sent, and it shows that a pH of 7.35, the carbon dioxide is 45, the PO2 is 55%, 55 with around 15 liter of oxygen, and the lactate is 4.5. So now with this clinical scenario, obviously all of us do understand that this is a case of severe COVID case, but what to do? And please, means if we interpret this ABG, what are the things which are going to come up? Now, if I look into the ABG, you can see that the carbon dioxide is 45, but the patient is having a respiratory rate of 38. That means even though the patient is hyperventilating, she is not able to wash out the carbon dioxide. That is, it is coming to a respiratory failure. Secondly, the lactate is 4.5. This could probably indicate two reasons. One, another, it could be a septic shock, because you can see that the blood pressure is 90 by 60. Secondly, it could be severe exertion for which the muscles is going to it's a state of hypoxia where anaerobic metabolism is taking place and lactates are more generated. So just looking into the lactate, two things also comes, that one is septic shock, second is the hypoxia that could probably cause it. So if we categorize the patient on admission, the patients who are having mild moderate cough with only low respiratory tract infection, they need to be admitted to a general ward. Patients who are having chest X-ray finds of pneumonia, even though asymptomatic, with a respiratory rate more than 25, saturation less than 95% in room air, but more than 90%, need to be admitted to a high dependency unit. And severe case, which our patients fit into the criteria, is she is having severe respiratory distress requiring any of the mechanical ventilator, or the respiratory rate is more than 30. Our patient was having 38 per minute, and the saturation less than 90% room air, our was having 74%. So it fits into the criteria of severe case, hence the patient was admitted to ICU. Now, this is something, the protocol of what we follow is something called as this ABC, that is airway breathing circulation. In ICU or in the critical care setup, it is something different, that is CAB. The first and foremost is that any patient comes, you have to get the circulation in order first. So how to get it? This is what we'll be discussing this case, that how we actually look into this CAB part. This is the area which I will be talking about. So this was the chest X-ray. You can see there is a bilateral pneumonia. I'm showing you this X-ray because this patient was immediately intubated, because we didn't have time to do an X-ray, and after that we are planning, because the patient was in the case of incipient respiratory failure, and we cannot do it since she was immediately intubated. She is quite a bulky patient also, because she is a known case of hypothyroid, for which the IV access was not so good. So initially we have put two large IV cannulation, but followed by which we have to put a central line. Now, how we actually manage this case, that is something which I am going to talk today, is only about CAB, that is circulation, airway and breathing. So whenever a patient of shock or a patient having low blood pressure comes, so first and foremost is to take care of the circulation. It is preferably done by getting a two large IV cannula, that is used, which we say is a gray line, to put two large IV cannulation to be done. because this patient actually presented to us in shock, so and with a lactate of 4.5, we don't know that whether it's a hypovolemia or whatever it is, but we suspect it is a septic shock. So here comes the fluid bolus. So 30 ml per kg body weight is the fluid which we give. So around 1.5 liter of bolus was given. The target in any case is to maintain a mean arterial pressure of more than 65. However, in this patient, after giving at around 1200 ml of fluid, the blood pressure had come out to 120 by 80, and the map came out around to be 70. So this patient was a could be was revived only with a fluid bolus and didn't require any vasopressors. So now, if we talk about resuscitating these hypotensive patients, crystalloids are always the preferred fluids. Colloids like gelatin, starch to be avoided or not to be used, because that's not an indication. But giving this fluid bolus of 30 ml per kg, but be cautious that this doesn't apply to patients specifically with chronic kidney disease, cardiac or old age, where there is a high chance of fluid overload. So there, small aliquots of fluid is more important rather than just giving the fluid bolus, which has been given in all of the septic shock guidelines. Catheter was put to see the urine output, and ABG was repeated after 2 hours to see the change in the parameters. Now, talking a bit about the airway, which was taken care of, because in this patient, how we have taken care of the circulation is that we have put 2 IV cannulas, given a fluid bolus, catheter was given, so all these things were done. However, airway means, in view of the respiratory distress and hemodynamic instability, she was intubated, because you need to understand that these patients, we didn't try NIV. The reason is that there is a hemodynamic instability. The patient is having hypotension. So any type of hemodynamic instability is more or less a contraindication for NIV. So that's why the intubation was planned. So it is always preferable to do a rapid sequence intubation, which I don't want to discuss further, but it's a part of which most of the intensivists must be knowing it. So this is something which we usually do. The most what the specific area in COVID is that the most technically sound person should intubate, because these patients have a very poor respiratory reserve. So if you take a bit more time in intubating these patients, they will desaturate very fast. So intubating these respiratory cases is obviously a bit demanding one, not like the normally which you do in the OT or other areas. So you need to have the most technically sound person to do it. And one more thing is important is that if you do not properly resuscitate with fluids before intubation, just intubating the patient immediately without resuscitating or taking care of the circulation part, which I talked about, will cause a profound hypotension, because the sympathetic drive simply goes away and the hypotension will be really difficult to handle. So this is the reason for which the thing of ABC is right now changing to CAB. So circulation has to be taken care of, airway has to be taken care of, and then comes the breathing. Breathing means intubating the patient is just a beginning. So what has been done in this patient is that she was intubated with a rapid sequence intubation. The mode which we use is a pressure regulated volume control. The saturation FiO2 to start is always 100%. We use a tidal volume because I have told that she is quite a heavy, and the weight is higher, and she's predicted body weight came around to be 80. So initially start with 480. The respiratory rate is 25, and sedation of fentanyl and atracurium was given. Ventilation in respiratory patient is always a dynamic process. This is what I always talk about. Don't think that once you have set a ventilator means it runs for 24 hours. It has to be supervised every 1 hour to see any change in pressure, any change in the rate, any change in the compliance, any block. So these are something to be taken care of. And continuous monitoring of the ventilator is the essential of a good outcome, because if you leave the patient without proper monitoring the ventilation aspect, then you make the patient more sick or you do more harm. So circulation, airway, and breathing. So these are the three parts which are very essential in the initial 1 hour. This has to be taken care of, and it is not that one after the other and after the other. It is always preferable to do it simultaneously, which is always done. Now, in a ventilator, of COVID, that there are some targets which needs to be achieved is that preferably the tidal volume is 4 to 8 ml, but use a 6 ml per predicted body weight, not actual. So try to have a low inspirated pressure, the P flat of less than 30. This is how you adjust your ventilators. You can permit hypercapnia, but your pH should not be less than 7.3. And we use PEEP by keeping the driving pressure of less than 15. But patients who do not respond to this ventilator part and still with all the measures you take is still hypoxic, then ECMO is an option. In centers who are specific means expertise in doing it, that is something to be there in our mind. So these are the part, and this is the target of all the ventilator, because whatever you do, there should be a target which you need to achieve. So in this patient, after all this, we have immediately intubated the patient because she was in a respiratory arrest state. Now the important part is next what are the treatments. So first is oxygen. Oxygen means not oxygen, it is oxygenation you have to achieve. You can achieve either through oxygen, NIV or invasive ventilation. In this patient, we have intubated and put on ventilator. Azithromycin, we use it at one tablet once a day. And because this is a serious or a severe COVID, so that's why the remdesivir is the drug of choice which we use. We started with the antibiotics of ceftriaxone because please understand this is a viral disease, not a bacterial that you need to go very high on the antibiotics. And antibiotics also will not help you in this disease. Then we use a steroid of methylprednisolone 40 milligram twice daily. Enoxaparin was given, which is twice daily as per the recommendation. Vitamin C and G. So this is what the treatment has been started. The investigations were sent and it revealed the hemoglobin of 10.8. The TNC is 5,600 with a normal limit. Urea, creatinine, sodium, potassium, everything was normal. The CRP was sent, which is very high, which is around 110. The D-dimer is obviously high. However, the procalcitonin was sent. The reason is that it is not mandatory to send procalcitonin on day one. But because this patient was having hypotension and features of septic shock, so we didn't knew that whether it is a bacterial sepsis that is also adding to it or it's just a viral. So procal might help you, or if the procal would have been a bit high, I would have thought of escalating the antibiotics a bit. Blood culture was also sent, but later it didn't reveal any growth. So how we actually continued with this case is that she remained in a sedated and paralyzed for 48 hours. We have done prone ventilation initially because she was requiring an FiO2 of around 90% to maintain a saturation of 94, 95. So proning was done for 16 hours a day. After that, we actually started to taper oxygen because she improved. Our target is that we always try to prone patients with patients who require a FiO2 of more than 60, because patients requiring more than 60% of FiO2, there is a chance of oxygen toxicity. So preferably we use proning for patients who require FiO2 of more than 60%. And we start to come down on the sedation and paralyzing drugs, means this paralyzing agents once the lungs compliance improve. So this patient has actually shown improvement after 3 days. So we have started to slow down of it. The paralytic agents are the first one to be taken out of it, followed by which the sedation has to be tapered down. So this was done. So this is from one more case, which we say is something called as a prone ventilation. So this actually helps in proper patients because the earlier you start, the better the result you will get. So we do it in severe ARDS, that is patients who are having a PO2 FiO2 ratio of less than 100. And it is usually we do it in the evening time, maybe around 6, and again the patient is made supine in the morning. So morning down, so he completes, or he or she completes a time of around 14 to 16 hours a day. But any patient with hemodynamic instability or patient who after proning desaturates, please do not continue the proning, because this will cause more harm than good. So patients with vasopressors and hemodynamic instability must not be prone at all. Now, talking a bit about what we say a fast hug bed. So this is what has to be started from day one. Day one means if your patient is on ICU, on ventilator, this all things has to be taken care of from the time go. So feeding, this is what we start within 6 hours also. So it is better to start, because if your patient is tolerant with, it's a well and good thing, because that improves or helps in recovering the patient fast. Analgesia and sedation are a must in patients with ventilators, because that's something which is very, very important. Thromboprophylaxis we have already started. Head and elevation of at least 30 degrees is a must. Ulcer prophylaxis has to be taken care of. Sugar control is something which is very, very essential in this COVID epidemic, because you are using steroids. The patients are having a stress factor. And secondly, we find that most of the COVID patients who land up in this serious scenario are actually diabetic patients. So glucose control is something which has to be taken care of very, very actively. And when the patient starts to improve, please think about weaning as soon as possible when the lungs improve. So don't be in a state that only after 10 days of ventilator or 7 days of ventilator weaning will be start. That's no. So once you find that the compliance have improved, the primary disease have improved, so spontaneous breathing trial should always be in our mind. Bowel regimen means the feeding, whether the patient is passing motion or not, that has to be taken every day. All catheters must always be considered that when it is not required, it should not be there. Whether it's a central line, whether it's a Foley's catheter, everything. And de-escalation of antibiotics, suppose you have gone high on the antibiotics, that must be considered, that whether it is required or not required, that has to be thought in everyday rounds. So this is what we say basics of ICU management, and this will more or less help you in saving more, means I would say 50% of the patients will improve with only these things, nothing else is required. So this is something which we talk about. So this is on day 5 of the ventilator settings. With this you can see that the shadow intensity on the day 1 have actually started to come down. So the patient actually has shown some benefit. So on day 8, actually she was off ventilator. We are doing a bit of TP's trial, because that's helps in knowing that whether the patient will be able to know the extubation, because previously when we used to do means directly extubate with pressure support, we found that these patients have some amount of myopathy or muscle weakness which persists. So that's why a patient tolerating TP's trial are better to be extubated and have a less of reintubation rate, rather than just taking out patient with a pressure support trial. So we are doing a bit of TP's trial, and on day 9 actually the patient was extubated, and the physiotherapy which was continuing from day 2 onwards also is something which has to be done, because please remember what we are finding in COVID is that they continue to complain of severe weakness, muscle weakness, myopathy, pain. These things are always there, and the best thing to take care is the rigorous physiotherapy, out of bed mobilization that has to be done in all patients coming out of a ventilator. And on day 11, with all the lines out, like rails out, catheter out, central line out, so she was actually moved out of the ICU, because we don't want to prolong any ICU stay. So she was moved to the high dependency unit, where this nursing care continued. And this is the day 11 X-ray before we were planning to discharge. Now, which Prashant Raghav sir have already told is that this radiological finding and the clinical finding will vary. Means in radiology you can find some shadow, but clinically the patient will be fine enough to be discharged and to go home. So don't just means rely only that once the X-ray is clear, then only we can plan for a patients to go out. That's not so. So there is always a clinical and radiological dissociation going on. So don't look for the radiology to decide that whether is fit to be discharged or not. And on day 14, actually, after the patient was able to take orally fluid, she can walk around without any breathlessness, and the saturation was 98% in room air. So she was discharged from our center. She was discharged only yesterday, and I have talked to him today morning. She is doing fine, and she is very happy. So this is just a small case, but if I again come to that, back to that question, that will my mother return? Obviously, the answer is yes, she will return. So I would say that these small victories gives our team some power to fight a long battle like COVID, and we will continue to fight it. So thank you for allowing me to present this case.
Thank you, Dr. Sampath. Again, you have shown a case who presented very sick, and you have kept the hope of the child and saved her. That is a great gesture, and thanks for adding emotion to this case presentation and also telling the message of management in the background of a very serious cases which you have been doing throughout. The questions have started pouring after other two cases will take. And with this, we'll move on to the next case by Dr. Shakti Vedanta Mishra. As I told, she is attached to the ICU at IMS and SOM Hospital, Bhubaneswar, and they are saving many lives, putting their best efforts there, and many doctors and many senior people are already treated and discharged from there. So I request Dr. Mishra to share his slides and start presenting the case. Dr. Shakti Vedanta Mishra, IMS SOM Hospital.
Thank you, sir. I'm trying to.
Yeah, welcome, Shakti. You can share your slides.
Yeah, I'm trying, sir.
Actually, below there is a green button. You are a co-host.
Yes,
So
sir.
below there is a green button. Share screen is written.
Yes, sir.
You have to open the slides in the desktop. Then you have to click the share screen and select the slides.
Yes, sir. I'm doing it.
So by the time Shakti attaches the slides, Dr. Prashant has answered all his questions. His first phase, he answered all the questions in the presentation itself. Then all which had come in the chat box is already answered in the chat box. So I think he is much advanced in completing his job. And those who had asked questions must have got their answer. Thank you, Dr. Prashant, for that. And still questions are pouring, and most of the questions are aimed at radiological findings, as you know. Dr. Shakti, you are having any difficulty? Oh, Dr. Shakti, are you there?
I'm there, sir.
Any difficulty?
Sir, it is saying host has disabled screen sharing.
You are in the same screen. How many screen you have? Oh, you are no more a co-host? Oh, I'm telling you. Yeah. Uh, just a minute. You are sharing one screen or multiple screen?
So one screen, sir.
One screen. You were a co-host. I think this has been disabled. हाँ राजीव से शक्ति वेदांत को कर दियो होस्ट. Dr. Shakti, you are a co-host now. You can share your slides.
Yes, sir.
Fine. That is top. You can open the slide. Are you able to recognize the slide?
Yes, sir.
Double click on that. It will open.
Sir, it is visible, sir.
Yeah, it's visible. You open your slide.
Sir, I've opened the slide. Is the presentation visible?
No, you just share this.
The screen is shared. Double click on the slide. So what you can do, you can open the slide in the desktop, share the screen. You can on share now. On share. Open the slide kit in the desktop, then go and then share.
So it's in the desktop, sir.
Desktop, you open it, open and minimize.
Okay, sir.
It's not opening, so you minimize. On share. First on share. Go to top and on share. At the top there is a option where it's written you are viewing Dr. Shakti Vedanta Mishra's screen.
Yes, sir. Stop share.
Stop sharing. Then you open the slide kit on the desktop or the laptop. Open it.
Yes, sir. It's open, sir.
Then you share and select that. Yeah. Now make it slideshow. Perfect. It's visible. Go ahead. Yeah, it's visible.
Thank you, sir, for allowing me for this presentation. Today, I will be presenting two cases of COVID-19, which we have managed in our ICU. So the first case was a 53-year-old male. He had fever and sore throat since last 5 days. And after he did the test, it came out to be COVID positive by RT-PCR. So he was referred to the some hospital. And on admission, he had a heart rate of 110, a blood pressure of 130/80, respiratory rate was 22, he had no distress, and saturation was 96% with room air. He had a temperature and he was quite obese. His BMI was around 36. And he was initially admitted to the ward. But on next day, he became breathless, respiratory rate increased to 35, and saturation was 88% with 10 liters oxygen through face mask. His heart rate was 134, and he was transferred to the ICU. On this was the X-ray which we had on the day of admission. On day 2, on arrival to the ICU, he was attached to the HFNC, but he still remained breathless and his saturation was not improving. So we did an intubation of the patient, and he had a NORAD requirement of around 5 mLs with 9 ampules and developed quite severe shock. And he was requiring a FiO2 of 100 to maintain a saturation of around 92. We had kept the keep around 12. So we, after putting the central line and the arterial line, we proned him and we started him on remdesivir and piperacillin tazobactam. No other organ involvement was there. We started piperacillin mainly because there was shock and thinking there could be some bacterial element to the shock. So this is the prone chart which we can see here. Initially, he was having a very low PF ratio of around 45. Gradually, over the time, his PF ratio improved and it became almost 200 after 18 hours. And PCO2 was still same, it is around 50. The peak pressures, which was 38, increased slightly on proning.
You can.
Yes, sir.
Please.
Yes, sir. On the day 3, next day, he was definitely a prone responder, and his PF ratio improved to 207. And we did a second session of proning because after keeping him supine for almost 8 hours, his PF ratios again came down to 110. So this was the X-ray which we did on when he was in the supine position. There was slight improvement compared to the previous X-ray, but this was mostly because probably he was on ventilator. He responded again, he improved, his PF ratios improved. It became more than 200 and stayed more than 150. So we did no more proning session on day 5. This was the X-ray, and we started our weaning process. And NORAD was stopped on day 5. By day 7, he was extubated to HFNC support. Actually, we kept him on HFNC because he was very obese. This is his video actually. But he was quite comfortable on. So on day 10, he was in room air. So we transferred him to the ward, and from there he was discharged on day 14. The second case is a similar case. It's a 67-year-old male. He had high-grade fever since last 10 days, and COVID was positive by RT-PCR. So he was shifted to SUM, and his arrival on emergency, he was very tachypneic and tachycardic with heart rate of 140 with BPs of 150 and 180, 90. Respiratory rate was 42, and he was actually having distress. Sorry, that's not. And saturation was 82% with 10 liters oxygen, and temperature was normal, and but immediate intubation was done in view of severe distress, and he was transferred to the ICU. On admission in the ICU, he was started on remdesivir, Dexona 6 milligrams OD, enoxaparin, BD, and proning was done. So this was the X-ray on admission. This was the this was the X-ray which he had done prior to admission. And this was the X-ray which was done post intubation. The infiltrates had slightly increased than before. So this was the first proning session. Again, he was prone with a PF ratio of 82, and it gradually increased to around 170. And PCO2 was slightly higher for this patient, 56. It increased to 62 and gradually decreased to 51. But his pressures were again slightly on the higher side, which decreased on proning and remained low. This was the day 3 X-ray. Actually, we were planning to do daily proning sessions for him, but because actually we now have a lot of patients and we can't prone everyone daily, so we did it the day after that. The second proning was done. This was the second proning session on day 3. Because as we could do proning on day 2, his PF ratios came down to 51. But after proning, it gradually increased to 130. PCO2s were again slightly on the higher side again, and the pressures were also on the higher side, almost 48. So on this is much improved X-ray on day 5. This was the day we did the third proning session. This we did in spite of PF ratios being almost 130, 140, because the pressures were staying high to keep a low PCO2. And this is the day we stopped the remdesivir. He had a good PF ratio 134, which stayed around 172, and the PCO2 also this time gradually decreased, and he had a lot of secretions which were coming out. Again, pressures also decreased. So after that, he was not given any more proning sessions. This is the X-ray on day 8, and no more proning sessions were required. Weaning was continued. On day 10, he was extubated and shifted to ward on day 13. And from there, we shifted him, discharged him on day 21. So proning is quite established as a treatment modality in severe ARDS. So this is the ProSEVA trial, which had shown that there is a 16% mortality, absolute mortality reduction. This is in the supine group, the mortality was 32%, while in the prone group, it was 16%. So there is significant 16% absolute mortality reduction. So it is recommended in all severe ARDS. So the take-home message for me would be prone, any patient who has a PF ratio of less than 150, early proning will have more benefit than doing it late. Do it at least for 16 to 18 hours, because sometimes, as we saw in the first case, the effect came after 12 hours and it was more around 18 hours. So do it for at least 16 to 18 hours to continue until the oxygenation is improved and also till the pressures are less. And it is better to put central line and an arterial line prior to doing it, because as such, the nursing load will be very high because of the prone position. So it is not, it will be more work for the sisters on the bedside if they don't have a proper monitoring of the BP and central line in place. Again, nursing care is very, very important in this case, because the patient is totally turned upside down, and pressure points need to be monitored. Always keep something in the pressure points, especially the elbow, the knee, so that they don't get any bed sore. So thank you for your patience, and I hope this helps in managing severe cases.
Thank you, Shakti. Both the cases were very clearly shown that the proning was useful, and good that you have used proning as a session in them along with the other interventions like antivirals and the steroid, and they have benefited out of that, and the message is very clear. And we at our centers in different places also have seen the effect, and there has been a discussion about the awake proning and their benefit. Thank you for bringing this as a message here, and thank you for being joining the webinar today. We'll take up the questions just after the presentation by Dr. Ashok Badmali. Please stay with us. Please unshare your slide so that Dr. Badmali can share. So that was Dr. Shakti Vedanta Mishra from IMH and Som Hospital, Department of Critical Care Medicine. He's an associate professor there. And now we'll move on to the last case presentation by Dr. Ashok Badmali, who is from KIMS, and again admitting the patients in huge number and following them up at the KIMS now. And Dr. Badmali will be presenting his case from KIMS. So I request him to share the screen and start presenting. Dr. Ashok.
Good evening, sir.
Yeah.
Sir, host disable participant screen sharing. It's the dialog popping up on my screen.
Oh, so you're unable to share again?
Sure.
Actually, you were a co-host. So actually, you were a co-host maybe because of this unstable connections. You were disconnected and rejoined. That may be happening. They're making you a co-host. You can say.
Sir.
Uh, there are questions coming in to Dr. Shakti, Dr. Shankar, as well as Dr. Prashant, and many questions are already answered by Dr. Prashant, and I'm sure we'll have a good panel at the end, and Dr. Patnaik is also joining, so we'll have to mark his presentation and we'll take up all the questions together, along with the very interesting cases of this IMS as well as Dr. Ashok, how many patients you are having in the ICU?
So presently we have all 45 bed full.
All four.
Sir. And 27 patients are on ventilator.
So more than 50% of these ICU patients are on ventilator. That's
Sir.
there is no room for any other who is in need of ICU. They have to go to other hospital. And HDU, you have HDU there? No. Uh, Teams has HDU. Dr. Ashok. Oh yeah, it's in. You can make it a slideshow. Ashok, make it a slideshow.
Sir.
It's fine.
Is it visual, sir?
Yeah, it's visible and there is slideshow. You're audible. Please go ahead. It's there. You can go ahead.
Sir, is it visible?
It's visible. It's visible. And if
Okay, sir.
you're unable to change the slide, please click on the slide.
Okay, sir.
Click on the slide and change. Your slide is visible and you are audible. Please click on the slide and change.
Sir. Good evening to all. So my presentation will be the use of NIV in COVID. So this was a case of 65-year male, extremely obese, presented to our COVID hospital with shortness of breath, chest discomfort, with a known case of type 2 diabetes mellitus and on oral hypoglycemic. On receiving in the COVID hospital, his pulse rate was 116 per minute and blood pressure 144 by 68, and he was very much tachypneic with oxygen flow of 7 liter and saturation was on 80 and 82. This was his lab reports showing suggestive of reports in a typical COVID patients.
Dr. Shakti, you are not audible. Please enhance the sound of your device. Sorry, Dr. Ashok. Yeah, Dr. Ashok, please enhance the sound of your device. Hello. Dr. Ashok, are you able to listen me? Your voice is not audible. Oh. Dr. Ashok, are you able to listen me? Sound नहीं. Niveta madam, are you there? Hello. Sound not sure. Dr. Pani, are you there?
ठीक ଅଛି ଆମର ତ ନେଟ୍ ଅଛି ନାଇଁ ଅଲଗା ମାନଙ୍କର ବି ଆସୁଛି ନା ଦେଖଉଛି ନା ଫ୍ୟାନ୍ କରୁଛି ନା
କଣ ଅସୁବିଧା? Sound checking confirm करें.
ଆପଣ ଟିକେ ଫୋନ୍ କଲ୍ କରୁଛନ୍ତି ଆଉ ଅଲଗା ଲୋକ କେହି ଜଣ
Sure ना किसी sound. और से लोगों से सभी लोगों को. So Dr. Ashok has some internet issues. He is trying to get connected by another internet provider because there is a unstable connection. He is trying to get connected by another internet provider. By the time we can share few of the questions. Professor Pani, are you able to listen? Professor Niveta Pani? Dr. Sampath, you can unmute yourself here. Is it audible to you?
Yes, yes.
Yes. Yes, sir.
With the his detail. Dr. Ashok, are you able to listen us? Dr. Ashok? Dr. Ashok? Dr. Your slides are visible, but your voice is not coming. Nivetha madam. Share कर दी। Disabled So I think Dr. Ashok is disconnected. So Dr. Ashok, can you listen me? Your voice is not audible. So you can unshare the slides and you can try sharing. Yeah. Again try sharing. Huh? Your voice is not coming. Dr. Ashok, are you able to listen us?
Yes, sir.
Your voice is coming now. So what is the issue? Any problem at your end?
Sir, am I audible now?
Yeah, you are audible.
Okay. Sorry for the inconvenience. So our case was a 65-year male of weight about 130 kilo plus, presented to the COVID hospital emergency with shortness of breath and chest discomfort. It was a known case of type 2 diabetes mellitus, and on receiving in the department, so his pulse rate was 116 per minute and a blood pressure of 144/68. Saturation on receiving was 80% with a venting mask of oxygen flow 7 liter. So since he was extremely obese and hemodynamically stable, as we have already seen in the first case presented by Dr. Sampath, since the patient was hemodynamically stable, we think for NIV support. And this was the lab reports of the patient, almost suggestive of a typical COVID patient, nothing in the infective line. On the day one, his ABG was with a low saturation and PF ratio of around 100, 10, 115. So we put him on, plan him to put him on NIV and injection remdesivir along with insulin and other supportive adjuvant therapy for COVID was started. And since he was obese and D-dimer was on the higher side, we have given prophylactically injection Clixen. On day 2, our plan was to give NIV 2 hour on and 4 hour off, because acclimatizing the patient to the NIV was our first concern, and to prevent the dry cough, intermittent dry cough, syrup ascoril was added. And during the off NIV period, he was either in the oxygen mask of normal oxygen mask or high oxygen mask to maintain a saturation of around 90%. And plan for plasma therapy was there. Due to non-availability of remdesivir, after the initial dose, he was switched to tablet 5e flu. So this was the vitals on day 2. In the evening, the saturation was 98%. On this AVG is on NIV. Still, just to because of his obesity and a stable hemodynamics and other advantage of NIV, we think to continue him in the line of non-invasive ventilation to be continued. This is on day 3. On day 3, when the patient got acclimatized to the NIV, we convince him and counsel him to intermittent awake proning and lateral positioning. After that, the AVG changes started improving drastically. On day 4, even on venti mask also, his saturation was 94%. But because of intermittent desaturation on later part of NIV, later part of oxygen mask, we have to put NIV 2 hour on and 2 hour on venti mask. So during that time, and since it was a VIP case, there was a suggestion from pulmonary medicine also to go for injection tocilizumab. He received 2 doses of tocilizumab within 24 hours. Awake positioning, awake proning, lateral positioning, and reclining position on NIV and on venti mask was continued at least 12 to 15 hours a day. On day 5 also, ABG was almost in a staggered value. This is the trend of blood gas on day 6, 7, 8, and 9. You can see the constantly improvement in the oxygenation level, and clinically, it's not in the chart, clinically the person's tachypnea got settled on day 8, and his room air saturation was above 93-94% on 5 to 6 liter of oxygen. On day 12, the patient on venti mask with a 5 liter of oxygen, his respiration rate was almost 15 to 18, and blood pressure was stable, and room and saturation was 97%. So, and the patient was discharged on day 13th with advice for 7 days home therapy and other adjuvant therapy, along with some kind of breathing exercise and pranayama. So now coming to the benefit of NIV in COVID-19. So why we have choose NIV in that case? Because a VIP case was there and hemodynamic was maintained, and he was having morbid obesity. So whenever we are choosing NIV, the patient's reflexes are preserved. Reflexes are preserved in the sense respiratory reflex, ciliary clearance, bowel bladder movement, positioning, these things are preserved. So when a patient gives us a space to preserve his reflexes, we should utilize that scope. Then oxygen support can be started early in case of NIV. Invasive ventilation is the last resort. So whenever there is a scope, go for NIV. Then it prevents hypoxic damage of endogram. So maintaining just in a venti mask or oxygen mask or high mask and giving invasive ventilation as the last resort, we are not visualizing the end organ damage due to persistent tissue hypoxemia. And next, nutrition can be maintained better in comparison to invasive ventilation. And another, in this pandemic situation, I can proudly say that it's the cost effective method, because many of the setup or ongoing setup, forthcoming setup, number of invasive ventilation unit will be obviously on the lower side in comparison to non-invasive. So we have to do triaging which are the patient where we can use this cost effective resource, and sedative and muscle relaxant can also be avoided, so the load on the intensivist or the anesthetist is reduced. Training of the junior doctors and nursing staffs for NIV is easy during this pandemic crisis, and the advice for patient positioning, there you can get the help of the patient itself and probability of less DVT. But everything has got its own limitation. NIV has got its own limitations, like you cannot use it in case of or uncooperative patients with unstable hemodynamics, non-fitting mask or a leak, or there is a time for adaptation to the flow of gas going around the oral and nasal area. Risk of aspiration is there, and whenever the patient is received as such in severe ARDS or a non-compliant lung, we cannot think for NIV in those cases. So the evidences are coming up for NIV in COVID. So review of early data shows more than 50% patients have reintubation, because it's the generalized weakness or muscle weakness which leads to reintubation in case of invasively ventilated patient and extubated. So NIV has a role in that post-extubation period also. And mostly in type 1 respiratory failure, secondary to causes like earlier collapse of the alveoli or widening of the gap like pulmonary edema, or in this COVID scenario, NIV has got a role. And the PEEP assists in maintaining the pulmonary recruitment. So the setting of NIV in case of COVID, it should be started from PEEP of 10 and FiO2 of 60, then titrated according to the patient clinical improvement or deterioration, and plan accordingly. So it may be a CPAP, it may be a BiPAP, or it may be a high flow nasal oxygenation. 3 modes we can use, but we mostly use CPAP in most of the patient. If the patient is having comorbidity, particularly like COPD or any cardiac ailment like post-stenting or anything, but no frank pulmonary edema, so BiPAP in those cases. From this, my take-home message is intubation in invasive ventilation is the last resort. Try the NIV first if it is indicated clinically and the patient is giving you a scope for non-invasive ventilation. Thank you, sir.
Dr. Ashok, it was a very clear presentation, and the message is very clear that we have to think of a option of going for the intubation at the end, and the NIV can be an important tool for the oxygen delivery. So with this, we have completed the case presentations. I invite all the panels. Professor Patnaik has joined us, and Professor Pani is there online. So,
sir, stop sharing, sir. I am stop.
Yeah, please stop sharing.
Thank you, sir.
Please stop sharing, and I invite Professor M.R. Patnaik, our head of pulmonary medicine and nodal officer COVID-19 at SCB Medical College, who has been there instrumental in saving many lives from the beginning. And Professor Pani, are you there?
Yes, I'm there.
You surface so that people will be encouraged to see you, and take up your opinions in the cases. And
Okay.
and then Professor Prashant is also there. She is quietly answering all the questions in the chat box, and I'm seeing the good work is going on. So I request the panels to please make their video on so that the attendees can uh, see them. And Dr. Shampad, I'm able to see Dr. Shakti is there, Dr. Ashok is there, Dr. Patnaik with me, and Dr. Niveta Pani and Dr. Prashant connected. Dr. Shamit Sahu had a emergency, and he'll be joining in the course of it. I invite all the panels. Starting from Dr. Pani, Dr. Dr. Sahu, and also all the presenters, Dr. Shampad, Dr. Shakti, and Dr. Ashok. And we had very nice cases giving a clear message on the break proning, clear message on the NIV, clear message on the critical care management, and all the cases were informative. So before we go to questions, because most of the questions are answered by our HOD pulmonary medicine AIMS, Professor Prashant Raghav Mohapatra. So we'll just put forth and the question for everyone so that all the delegates can again get the message. But before that, I'll try to take the opinion of the panelists on the cases. So to speak, Dr. Niveta Pani, your opinion on the cases presented, Dr. Shampad, Dr. Ashok, and Dr. Shakti. Madam. Madam, please unmute yourself.
Am I audible?
Yeah, you are audible.
Hello.
Madam.
Hello.
Yeah, you are audible, madam.
Please ask the question. Jayant is not audible.
No. Will you comment anything regarding the cases presented?
Yes. Am I audible?
Yeah, you are audible, madam.
Yes. My comment for the Shakti Vedanta case is that hello.
Yeah, you are audible, madam. Please go ahead. You are audible. Please unmute yourself. Yeah.
It's very good.
You are not audible now. Ma'am. Have you unmuted yourself?
I think the audio is disconnected.
Madam, you are not audible. Unmute.
Jayant, I'm not able to hear your voice.
Yeah, are you able to hear me? No.
Tankar problem.
There are some differences.
Network problem.
Dr. Ashok, am I audible to you?
Yes, sir.
So maybe madam is having similar problem like you had. Madam will take some time to get connected. We'll take up Dr. Prashant. Dr. Prashant will take up your comments on the case. You have to unmute yourself.
And what you were asking, I was discussing something else. And please, sorry.
You have heard two few cases presented by Dr. Shampad, Dr. Shakti, and Dr. Ashok.
No, not much of question. Sampath case I have seen, that is a nice case. The rest I missed it because I have to go to see some patients. So in between I was not there. So all are fine. And
Yeah.
last NIV case was also okay, but that is
Fine. So then we will take up the questions. Madam, are you able to hear us? Then we'll take up the question. So that will be good. I think Dr. Prashant, most of the questions to you we have answered, isn't it?
Yeah, I have answered. I have formulated some questions also to clear up the queries, whether HRCT or CCT, whether CT scan is a must, whom we are doing to CT scan, and what is the best time to do a CT scan so that I have already discussed in my slides. And any question I can take. I mean, I may not be doing. Data are evolving, things are changing over the time. I mean, so we may take whatever they ask, we may discuss.
Yeah. So nicely you have ensured. You have all FAQs, frequently asked questions, you have taken in your presentation, and here also I'll just read out your comments. The HRCT of lungs is confirmatory criteria for COVID-19 diagnostic purpose. Somebody has asked, is it confirmatory? Can a diagnosis be made from the CT scan? So the answer is it can be suggestive, but it's not the diagnostic criteria. So can CT finding be used to decide treatment protocol, especially use of antivirals, and which one? Clinically,
That has been controversial, but particularly in clinical constraint, if a clinician feels that it is nothing but COVID, so they can go ahead of this, go ahead of treatment. There's nothing say no. Regarding antiviral, you know the role of antiviral as of now, where you stand, where CDC and others and NIH is recommended. Everybody is aware of that, but you can give it. If clinically you feel that person need and can be given. And particularly somebody asked remdesivir, I think now it is becoming more generalized. Also can be given means not in severely ill, that can be given to other patient also, but this is an IV drug that need to be admitted. That is the only view. That's all.
so where does the ground glass opacity locate in early phase of COVID-19? So you have shown the pictures, and
Yes, ground glass opacity starts because at the time of initial inflammation, the alveoli gets filled. So that is the alveoli shadow that presents as a more or less ground glass opacity.
lower zone, posterior, lateral, usually peripheral.
Usually multilobar, peripheral, posterior located, and lower zone are involved. And sub-barments can be segmental, subsegmental, oval. It can be any type. Usually subpleural, peripherally located.
Opacity in the ARDS and CT findings are similar in the COVID opacity. So it is.
I think Dr. Sampath can answer this in the better way because he is dealing. But problem is that most of the ARDS patients who are unable to do CT scan because CT is not in the bed. So you have to shift it, and the patient life is more precious. And shifting is in a transport ventilator is not always easy, particularly COVID setup and taking all these precautions.
Actually, am I audible? Practically,
Yes,
it is very taking a ARD. Am I audible?
Yes.
Yes, ma'am.
Practically, taking a ARDS patient for a CT is very difficult, and to depending upon the CT, I don't think it is so easy for a COVID patient.
Yeah. That's totally. Then also it will not change the outcome. Also, it may change ours.
What I would suggest, sir, means what we are finding these days is that many doctors who are not dealing with COVID, even though X-ray is showing a frank shadow, they will insist the patient to get a CT done, even though they are RT-PCR positive for COVID. So I don't find that why means if someone is X-ray shadow is positive, RT-PCR is positive for COVID, so that means putting the patient for a CT scan will not change anything in our treatment plan. So this is something which it's unnecessary.
True, Sampath, very true. Because its recommendation is RSNA, Radiology Society of North America. They said only CT is indicated in moderate to severe cases, not in mild cases. Even if you get a patch on X-ray, it doesn't need to CT to be done. And ideally to be done in around 5th to 7th day or 5th to 8th day when disease is evolving. That is the best time.
We should not give much emphasis to CT scan. As,
True.
Yeah, it's been emphasized. And if there is all feasibility, patient is stable, and you have facilities available, then you can do it and correlate. I'd like to know the opinion of Professor Patnaik regarding this.
So, as you know, the radio CT scan in the standard teaching, it is very difficult radiologically differentiate from pneumonia and ARDS. This is standard. Here in COVID also there is pneumonia, viral pneumonia. So to difference radiologically, it is a ARDS shadow or pneumonic shadow. It is very difficult.
Yes, sir. This is difficult.
Standard teaching, nothing new with it. And regarding the management point of view, so CT has got no role in the pneumonia or ARDS. Rather, the blood gas will differentiate what to do, what the further step of action. So definitely here, definitely if you have got a ABG, you must have a PF ratio. That is the ideal what policy you will adopt in this patient. So radiology has got no role in for ARDS and pneumonia differences.
That's very clear. Just it's a clinically corroborative finding that you can do. So with this, we'll move forward. I think we've answered all these questions which has come in the course, and this question also answered by Dr. Prashant. X-ray picture of the moderate and severe patients. Ground capacity is typically with the peripheral and subpleural distribution. I told the involvement of the multiple lobes, particularly the lower lobes. These areas of ground glass opacity may be admixed with the areas of focal consolidation, typically superimposed intralobular reticulations. He has asked regarding the after rigorous treatment, X-ray finding not changing. Uh, so that also you have answered.
So I'm reading. Actually, what has happened, X-ray again depends on what time we are taking X-ray. X-ray taken at the right time. At times, severe pneumonia, it may take 6-8 more than 8 weeks to resolve. Even if may not resolve, there's some shadows too. Normally, what happens is as good as other pneumonia. Clinically, patient may improve early, but radiological shadows lacks. So it may 6 to 8 weeks to resolve to some extent. So that means so X-ray shadow will remain for a long time. So even if CT shadow, but that residual shadow, it depends on the degree, not only degree of involvement and also extent duration of disease. Because any inflammation, it doesn't heal on time. It will heal with residual fibrosis. That has to be acceptable, and we should accept the reality. So that's why your post-COVID rehabilitation is must for most of the severe patients.
Right, we have answered that the shadows will take time to resolve. So you should not expect that when the disease clinical resolution is not radiological resolution. That has been a standard teaching, and categorize mild, moderate, severe on the basis of CT scan. It's not done because we have variations. Few people with severe disease have minimal X-ray picture. Few with minimal disease have severe X-ray picture. And diseases progress, regress over time, and the Corars describe the probability of having COVID-like picture, but not as per the severity. Very well ensured by Dr. Mahapatra. So with this, we'll go ahead. The next question is, what is the latest data on mortality of COVID patients on invasive ventilation?
So it's difficult to answer. So it depends on age, depending on comorbidity, the duration of illness, and depends on who is doing. Sampath is doing or Prashant Mahapatra is doing. That makes a difference. Old generation, new generation. So
but I'll say what I think, and there is lot of studies that definitely NIV ventilation is definitely better than the invasive ventilation if the patient is having comorbidities and all.
Yeah.
Also, there is a study.
Actually,
There is a study in the New England Journal. So they found that there more mortality in case of invasive ventilation and less mortality in non-invasive ventilation. But depend upon at what stage you will take the step. That is very important. Suppose patient has got a extensive bilateral disease, and you have got the PF ratio very low, less than suppose 150, and in that condition you take a decision to put the patient in the right time. So not early, not late, at the right time. Intubation environmentalist definitely help the patient.
Yeah. That's important. Right time intubation and right time weaning. I think Dr. Mahapatra was telling something.
So I was saying, in between you can use HFNO, high flow nasal oxygen. It is available. It can actually help some patient before taking to avoid mechanical ventilation. You know, the morbidity, duration, and mechanical ventilation. We don't have that much of ventilator. So if you the state and the institution can have some high flow nasal oxygen, that can be good use. That means if somebody is becoming, you are not able to maintain saturation for a short time. It is just I think it's just a buy time for few days to few weeks. That's all, patient will improve automatically. So if you get HFNO can be useful if you can buy and give it. That's my say.
One point regarding the government of India, now they have stopped the HFNO, purchasing HFNO. So what will do? This is a guideline from the government of India for purchasing HFNO.
So I think guideline maker and procurement division are different. It's like they should be same.
So, procurement
Definitely, HFNO will be the better option.
option is there, but in the COVID hospital, you will not get that HFNO because of the government of India stopped purchasing HFNO. This is a clear-cut guideline is there.
Yeah.
I think it's a different setup. Is you need of that much of flow of oxygen to generate to use a utility. So giving a HFNO in a small cylinder, I think that may not be appropriate.
Everybody is under government of India.
Yes, sir. I know, sir. But I think the recommendation should be there more of pushing ventilator than HFNO.
Yeah, actually, what we have observed, the people on HFNO and NIV, they have recovered, though it has taken little time, they have recovered in a higher number than people put on invasive ventilation. And as Dr. Ashok presented, this NIV and HFNO has helped us, but unfortunately the guideline has changed, and I'm sure there will be room in the future. So
I'm sharing my experience, and I published, I think, the first case from India from using NIV, particularly 2009 H1N1 pandemic. You see, Chandigarh has been mostly affected. I've seen means 7-8 people are dying in every day coming to hospital. When not much of ventilator that time, all ventilator used when patients are sinking. Where to go? You have to use whatever you have. I have survived actually 2-3 patients. They have it's a matter of buying time for a few days. If you can maintain, if it's not able to maintain 80 saturation, if you get it somewhere around 88, 90, even giving a supplementary oxygen and NIV, this patient you can buy 3-4 days, 5 days. Patient used to come. Some patient used to come back. Means this is a support I have seen. That means, and later on I saw that some paper has been published. NIV, particularly H1N pneumonia. I think it's all depending on which patient you are using. You have to selectively use where it's going to affect it. Where means NIV fails means you need a ventilator for that. That has to be resolved.
So that's a message is that how early we intervene. In the early stage intervention by
yes, sir. You should intervene as early possible. Early intervention will going to help. I think Dr. Sakti and Dr. Sampath can give a better answer for that.
Dr. Sakti.
Yes, sir. So what I have seen is, sir, it is better to, if the patient is having decreased in oxygenation, we better to go for HFNO because it will maintain the oxygenation for a longer period. If the patient is going still not maintaining saturation or HFNO, then my personal opinion is to go for an intubation. But then to buy time, we can go for NIV. But then I have seen, my personal opinion is that NIV is not going to be of much help. Yes, rather, it causes more harm. So it is better to intubate if the PF ratios are going less than 150.
Yes, true. I think early intubation, early recognition, and early intubation, that is the key.
So, what is the opinion of Sampath, sir?
It will be same, sir.
Sir, thing is that you have to categorize the patient who will benefit from NIV and who will not. It is not that all patients should be put on NIV or all patients should be put on invasive ventilation.
Yes.
Suppose you see that a patient is really sick and means hemodynamic unstable, PO to FI2 ratio is less than 100. So there is no chance of putting NIV and looking for it. And suppose you find there is only mild hypoxia and you have put on NIV, the respiratory rate has come down. So I would say this is more of a clinical judgment that in the initial part of it to help you in deciding whether NIV will be help or you should directly go for invasive ventilation. So that is something which has to be taken care of. Means personally see and decide rather than just give NIV to all patients or invasive to all patients. That should not be the attitude, sir.
And one study is there. He has mentioned that patient who is failing to NIV and putting in invasive ventilation, the mortality is high.
Sir, obviously, thing is
I want to
that
say
I have
something.
already
Obviously.
told many a times, NIV sometimes gives us something called as a false sense of relief. So this is something which should be avoided, because many a times it has been found that if you use NIV, you are actually late in intubating the patient, and you intubate very late. By the time everything is bad. So that's why something means if NIV, we have to be judicious also that when to stop NIV and put on invasive ventilation rather than continue it to a last stage and then intubate.
Okay, Dr. Sakti, your
Yes,
comment.
sir.
I just wanted to add one thing. Actually, this is a confusion when to stop NIV and intubate. What is the opinion is, if the patient is having a higher respiratory rate and a higher tidal volume on NIV, then it means that you are causing more lung injury and it is causing more harm to the patient. So if the respiratory rate is more than 25 and if the patient is generating a tidal volume which is more than 6 to 8 ml, it's better to go for intubation rather than causing more harm. I think that should be the criteria when we should change over from NIV to ventilator.
This part also very important. You have
Yeah.
to take care of these things.
So, as discussed, you have to start intervening early, maybe oxygen therapy, maybe HFNO, and in the proper time, you have to go for every intervention. If it is delayed or you are doing it at the wrong time, you can do more harm than good. With this, we'll move ahead. The next question was on silent. First, it is even after. How do we identify asymptomatic carriers? Does children belong to this category? So somebody has asked about the asymptomatic carrier. You know, in this stage of pandemic, anybody you are testing for the disease, and it's very difficult to tell. Now, rather other way around, I'll tell you have to follow the universal precaution, and you have to presume that everybody is positive instead of finding out asymptomatic carrier. And the message has been there. The children infect many people, but being immunocompromised, they may be symptomatic also, but they go everywhere. They have a universal penetration. They can be spreading. So I would like to know the opinion of other panelists and the speakers present in this matter.
So regarding asymptomatic carrier, very, very important for the spread of the disease.
Yes.
You know, 20% the asymptomatic carrier, they spread whole disease. Well, 60% of the patients who are the infected and with symptoms, they infect one-to-one infection. But asymptomatic carrier, they are really the super spreader.
Yes.
So, whenever there is any history of suppose is from the zone, contact zone, and everything, and there is a history of a contact. So there should be also any history of contact with a case, positive case, whether symptoms or there is no symptom. Is the examination of the throat swab is a must.
Sure. So any suspicion, you have to examine, and if there is a contact, 5 to 7 day, if it comes negative, also you can repeat.
And also the contact tracing also is also an important thing to trace all those asymptomatic carriers.
Yeah. So Professor Narayan Mishra has wanted to add a little regarding the radiology. He has watched the program and appreciated the presentations and wanted to add. So, Professor Mishra, are you still with us?
Yeah. I'm from the very beginning with you all. Very good evening to all of you. There is some problem in the, video. I'm not surfacing out. It was an excellent talk of Raghav, I can say, Prashant. It was nice. And I was just listening. that there is difficulty in doing CT scan. Definitely, in the severe cases, as Sampath was telling, and some newer and easier and cheaper modalities are just coming out. That we all know. That is the Spanish group. They are working on ultrasonography, and they have compared the ultrasonography and the CT scan along with the indeterminate cases like the RT-PCR is negative in those cases. They have found even ultrasonography is better, giving better result than the CT scan, and it can be easily done. It is portable, and also it is cheaper. That's the thing. And the second thing regarding this CT scan, it has come out only about 3 to 4 days back. That is in the Journal of European Radiology, that ultra low dose CT they are just bringing out, which will based on this deep residual neural network, and they are working on it. Just that I wanted to.
Sir, low dose CT is always there for the screening of the lung cancer in the ATS guideline. Also,
Yeah.
low is there. But
Yeah, COVID now they are working on, and this is just published on 3rd of September, and that is in the Journal of European Radiology, that they are working on it. That is basing on deep residual neural network, and they are doing it.
yeah, that is the basis is that because there is also involvement of reticular system in the alveoli, around the alveoli. So to detect that might be
High resolution is required. Yeah.
might be those CT will be very helpful in that cases.
Yeah. Any panel to add anything to this? I will move ahead.
Sir, one problem with the ultrasound and
Yes.
that basis patient cannot be admitted. It is just the administrative point of view I am discussing, not a technical point of view. Because in ultrasound, if your RT-PCR is negative, nobody is admitting to the.
No. I am not telling, Professor Patnaik, I am not telling that. Whatever the study has been done, that I was just quoting, that the sensitivity and the specificity is better in ultrasonography little better than even CT scan. That I have just wanted to say. I have never said that don't do RT-PCR, go for that. Just I was telling that this is a newer and cheaper modality which we are looking for now. That's the thing.
Ultrasound is really good, but problem is
again will have to be
has restricted the hand of the pulmonologist and interventions to use ultrasound. CT cannot be repeated daily. Ultrasound can be done daily basis to monitor the patient. But again, it needs expertise for that.
Expertise, yes, exactly. That's the thing. Yes, Raghav, I agree with you.
Expertise hand in for the detection of this lesion.
Yeah, that's very important. And the question also had come: why to use a long ultrasound in COVID-19 patients? What is best to use the long ultrasound? Dr. already covered its position, and there is a question to Dr. Sampath. Role of remdesivir in severe COVID.
Procalcitonin is normal.
Where the procalcitonin was normal, and did you de-escalate the antibiotics? Antibiotics being misused in COVID management. So, Dr. Sampath, will you?
Sir, the thing is that remdesivir is an antiviral. So obviously, patients who are in severe COVID, antiviral of choice is injectable, that is remdesivir. Secondly, here we are not using a very high antibiotics. I have told that I am using ceftriaxone 1 gram twice daily. So I have not done to a very high carbapenems or BLPLI that I need to think about de-escalation of the antibiotics. So it was only added because the patient was having a features of shock. So we thought that could be some amount of sepsis, but she responded to the fluid management and using a ceftriaxone just to take care of some amount of bacterial infection. But here I'm not used any high antibiotics that I'm going to think about de-escalation.
And again, one thing he has told that the Procal is normal.
Yes, the reason I have also explained in my presentation why I have done Procal in that patient is that the patient presented to me in a shock phase with blood pressure 90/60 and lactate of 4.5. So I don't know whether it is due to hypovolemia or there is a secondary bacterial infection that is taking place. So we need to think about some type of infection also in the COVID. It's not that COVID will not have any bacterial sepsis also. So I have means it is very unlikely for COVID patient to present to you with shock unless and until there is some amount of sepsis which is also playing a role. So that's why I have done a procal in this patient. Otherwise, mandatorily doing procal from day one is not indicated.
Practical, initially last time also in H1N1, we have seen that the fever is appearing the second week, that 7 days, after 7 days, it is probably due to secondary infection. And during that time, the secondary infection was most commonly staphylococcal. And in typical viral pneumonia, you get a typical symptom. But when there is a secondary infection, you get a typical consolidation setup. That was the classical disease. But here, COVID, there is also there is change also in the features, presentation features. Suppose on the second week we are getting a fever, we think with a rigor, we think that patient is going to cytokine stop. That is another option also in the COVID.
Sure.
Sir, we are finding cases, means patients are getting discharged and after they will be getting discharged on 10th or 11th day, but maybe returning after 5 to 7 days with again high grade chills and rigor fever, DLC around 20,000. So, and the X-ray shadow suddenly flare up. So we are finding these cases. I have already admitted 3 of them, and there from day one I hike up the antibiotics to a carbapenem and I find a good results. So there is a chance of secondary infection which Patnaik sir is telling, and this patient will go back to the home and will come back with again with sepsis.
Yeah, many people are admitted again after adequate treatment with the antivirals and the oxygen therapy. And because of the secondary complications, like we have seen cases with bacterial infection, with pneumonia, with thromboembolic phenomenon, we have seen. So there is a question regarding the fibrosis, long fibrosis, the latest guidelines, and already Dr. Mahapatra has replied the pulmonary rehabilitation and the making them fit subsequently. Only future will tell regarding that. And there is a question regarding the testing of contacts of an office colleague. So you have to quantify the contact, within a 1 meter distance. If the contact is more than 30 minutes, maybe without mask, it's a high risk contact. If it is with mask and beyond 1 meter, maybe less than 15 minutes, it's a low risk contact. And as per the risk, you have to stratify and get tested from 5th to 7th day. And if it is negative or you will develop symptoms, you can repeat your testings as well. So there is a question: high risk here would mean people with comorbidities or anything else. Comorbidity is a different story, but high risk means this criteria: the distance and the duration, and whether you are with mask or without mask. They are taken to quantify it's a high risk, low risk, or no risk contact. So there is a comment by Dr. Tarun Mishra that X-ray are universally available, not CT scan, and also they have he has told that we are using HFNO and the NIV in moderate cases. In severe cases we are going for intubation. So that's at large taken.
At large, we agree with that. Agree with you.
We so with this, we have covered almost all the topics. I'll like to opinion of the panel before we close. So to start with, Professor Prashant Raghav Mahapatra. So we had a good interaction, and your presentation has evoked many questions in our audience, and the people will be watching again in the streaming link of the YouTube. So, what message finally you want to give to our attendees regarding radiology? That maybe X-ray, maybe ultrasound, maybe CT scan in COVID-19. How much importance and when to do and how to interpret the final message before we close the session.
Regarding all indication, I think we should follow the change evolving guideline by Minister of Health and Welfare, the uniform guideline, and the guideline remains silent regarding radiology. I am to very clear, but only where the facility is available, only moderate to severe patient. We should also do simultaneous not only the radiology, if as much feasible, we should monitor the other inflammatory parameter like D-dimer, other part, that means the ferritin, procalcitonin, whatever you have, we need to, whatever you suspect, depending on the patient to patient, we must to verify it. And radiology is not must a patient, but at times, when patients not improving, we are suspecting that I showed in my experience in last 2-3 weeks in my ward, those are RT-PCR negative, patient symptomatic, and finally they are actually in particularly in context of COVID pandemic, there's nothing but COVID, they are COVID-19. So that has to be high degree of suspicion is more important, and patient management has to be uniform to all as per the guideline. So I think not much to discuss, but radiology only moderate, mild to moderate patients where you need it, and particularly 5 to 7 days. 5 to 7 days is most ideal time.
Yeah, because with time we have become much richer in our experience with the radiological findings. And this can be another clue. Suppose one clue we have missed in the RT-PCR or rapid antigen. It can be a clue where we can retest or track the patient or isolate, as you have seen initially. Because of your radiological suspicion, you have sent the patient back to isolation and finally proved that it's a case of COVID-19. So thank you for the nice presentation, Dr. Mahapatra. It has left a real message, and we'll be taking your expertise in future sessions also. Now I'll ask to Professor Niveta Pani, what is your final take-home message on the HFNO and NIV? Because there is a lot of confusion. Initially, we were telling HFNO and NIV are contraindicated as aerosol-generating procedures. Then we saw that in mild to moderate patients, they were life-saving, and we tried to defer the intubation by that. And again, the guideline has come, as Professor Patnaik has made it clear, the government is not procuring any HFNO.
Because today for SCB, I told them to procure some HFNO. But they told straightly the government of India guideline, they cannot purchase HFNO. As a government hospital.
Professor Pani, the master in oxygen therapy, what do you?
Jayant, I always feel definitely in the mild to moderate cases, HFNO and NIV will be definitely helpful. Because unless we see the PO to FI2 ratio and clinical problems, you go for a intubation or whatever, unless it is needed. So even if the government of India doesn't agree for the HFNO, definitely I will always support for the HFNO, because really it helps in a really certain cases. HFNO is very helpful. Practically it is helpful. And NIV also, NIV has got also a role. Definitely mild to moderate cases also, NIV has got also role. Unless you see clinically the patient is getting adjusted and is not able to maintain the PO2 or FI2 ratio, then you can go for intubation. Definitely before that, these two cases will be important. And to be very practically, I will say that intubation is not so easy job. At least NIV and HFNO can even by, you can say it will very easily you can give the patient than for intubation where the highly expedition is needed. This is my opinion.
Ma'am, Dr. Mishra here. Regarding this HFNO, how long you can give? Now it has been seen globally that due to this, probably if it is used for a longer period, we are entering, though the patient is recovering, entering into the stage 4, that is the fibrosis. More the oxygen, more the fibrosis. So it is better to go for intubation at an early stage rather than giving this HFNO and also going for this NIV. Is my opinion. I mean, global opinion also says this.
Yeah. So we had a
Sir, intubation, there are two things practically. If you see, first of all, highly expectation is needed for intubation, and every cases everywhere to get an anesthesiologist or to give a intubation is not so easy, sir. At least for mild to moderate cases where you can give HFNO, it can be helpful. NIV can be helpful. I do agree, sir. Definitely intubation is helpful. But if you can take a statistics also, the morbidity, if you look at once a comorbidity patient go for intubation, it is very difficult to revive from the intubations. This is my opinion. I don't know what about your Dr. Patnaik? What do you say?
So my opinion will be early detection of hypoxemia. And I know that the only therapy what we have observing, these oxygenations with proning is the only way to tackle the situation.
Exactly. That's I agree.
How early did it? So I also told by every day you do a good round and detect which patients are hypoxemic. And early intervention definitely is helping, and also patient being is cured. So whatever maybe is ready. So definitely patient from the patient point of view, coming to the hospital early phase, early symptomatic, and we detect also early hypoxemia in the early stage, and only intervention is the oxygenation. No drug will help, only except dexamethasone sometimes that helps. Otherwise, no antiviral drugs helps. Or even if we are not sure about the plasma, which is it due to itself oxygenation or due to plasma, it is very difficult to tell.
So I think, thank you, Professor Pani, for your opinion. Thank you, Professor Mishra, for the opinion. Actually, we know it is a evolving science, and as per the evidence, we are coming through different recommendations. But as we see, definitely to delay the intubation, the NIV have knows where to stop, where to start, as Dr. Patnaik told, how early we can detect hypoxemia and how early we can use oxygen that saves the patient. And thank you for that opinion. Before we close, I request Professor Patnaik to tell something regarding this awake proning. Awake proning is a very important practice, and we don't spend anything for that except putting our housekeeping people to help the patient in changing position, and that has shown a big benefit, as already presented the case by Dr. Shakti. So, what is the message to the COVID doctors regarding awake pruning?
So actually, a practical problem is that suppose the doctor is going once and they're telling to the patient, and he is not obeying the order. Practically, proning is not happening with the patient. If you simply you tell the patient is so, that is not happening. So the doctors from the beginning should tell the patient. Suppose say half an hour initially a patient is coming, you are telling proning. So every half an hour you go and see that patient is doing proning for 2 hours, then you can that patient will gradually win. But you just have do proning, they are not doing. That is a practical happening. And those not doing proning, we are not getting better result.
Yeah.
You are obeying the order.
Yeah.
Fine.
Maybe the benefit is obvious, but
So,
to practice it
so frequent counseling is required to the patient.
Yeah. So
Sir,
it out becomes difficult. Yeah.
sir, I want to add one thing. I do something in during the patient counseling. You be in the prone position for 30 minutes, 30 position on left lateral, 30 minutes on right lateral, and air has the property to go up. So if you are in the proning, your backside will get better air, and all the secretions or sputums or cough like things deposited there will come out, and you will be relieved from COVID in a early time. So after listening to this type of counseling, they are doing proning and this positioning change themselves proactively.
Yeah, it's better to tell patients directly than to tell your.
Yes, sir. Because I told them air has a property to go up. So if you are on the left position, your right side will get better air. So by doing this, you are filling with your lungs with a better air in all 4 quadrants. So after that, they become proactive.
I think only proning will be successful if there will be counseling, good counseling.
Yeah.
That is very important.
Rightly, Dr. Ashok has practiced that because it's for the interest of the patient. If patient is convinced, and nobody can check him, and you don't need medical to do that.
Yes, obviously.
themselves will do that.
And
So,
after that also 10 to 20 incentive spirometry, like long inhalation and exhalation every 1 hour. So it will bring oxygen up to your diaphragm level, or else in a shallow breathing, oxygen is going up to nipple level. This is the word I told to them. It may be unscientific, but they are convinced. Then they do the things.
You have to create some method
yeah,
by which you,
yes,
that is very
I think you are following the right path.
I think here I can add that if not incentive spirometry is not available, you can ask patient and convince that any respiratory breath holding can be an alternative for to incentive spirometry, that can, in addition to prone positioning. I think Dr. Also you can agree with me.
Yes, sir. Even after this counseling, few of these mild cases, they have to Kapalbhati also.
Yeah.
No, I think
All this
Anulam
exercise.
Vilom. No, Ashok, I have to add also, Anulam Vilom has got also a role for this health.
Obviously, they have to make aware of their breathing pattern and the benefit.
That's important. Dr. Shakti, you want to add anything here?
Sir, regarding the prone positioning, actually, I myself, when I was suffering, I used to be in prone position. So did really improve my saturation. But since we mostly deal with ventilator patients, I have not done any awake proning in ICU. But I'm sure it definitely helps. Regarding HFNO, sir, there is one more problem, that is the requirement of oxygen, the flow is very high. Sometimes if you use too many machines, your oxygen plant can get uh,
Yeah, true. I was saying from beginning, cannot be
yes.
fitted everywhere.
uh, so that is
No,
can be.
where there is liquid oxygen plant, you can use
Yes,
it.
yes, yes, yes.
Obviously.
But ma'am, it still gets exhausted. That's what it's in the. I mean, Europe, they have seen all plants got exhausted because of it.
Professor Patnaik, Dr. Mishra, I am not seeing the patient, or I am not in the ICU, but from my home, I see that my patients are getting prone position in the ICU. However, you just see many of my friends, many of my patients are in ICU. What I used to say, please go to the prone stage and see how much oxygen requirement is there. And they say that it has improved, sir. Now it is 99. When I was in this supine position, it was showing 92. Then I used to say, you see, if you take more oxygen, more fibrosis will be there, more post complication will be there. So whatever, I mean, stay is here, they are in your hospital, you just say. And whenever they ring me, I ask whether you are in prone position or not. So that is probably the best thing what Professor Patnaik has told.
because you are giving a good counseling. That's why you are testing. So, hoping to honor captain.
Thank you.
We have to say patient that you see your CT shows that your peripheral and posterior locator shadow that's remain posteriorly because you are looking up. Now looking down and have a prone position so that your secretion will come down and come in central airway and get it cleared. So that's a little better.
Yes.
So it's very difficult intellectually. We have to devolve and go to the patient's mental level to convince them. So that is the important thing. And Dr. Sampad, are you there? I think Dr. Sampad has gone in emergency. So any panelist to add anything before we close?
Sir, I wanted to ask something.
Yeah. Shakti.
To Prasad Mahapatra, sir.
So,
Sir, the FAQs are very nice, sir. I had all those questions. Can I get them so that I can read them again? So the FAQs you told in the end regarding the CT use in COVID.
And then I thought people have so many queries. So FAQ what?
Sir, I myself had those queries. So actually, I wanted to. Can I get those slides or in some
FAQ?
Yes, sir. The FAQs.
Yes, I'll send you. Just send me my email. I'll send it. Don't worry. This is for this. I'm not going to say anything. So this it's for education only. That's all. So I try to simplify rather than the pure radiological form to how to differentiate between other shadows. That I try. And so FAQ means this is really the people who are having similar question among our residents. So I think that's more.
Myself has good questions.
Thank you.
Sir,
thank you.
Yes, thank you.
Actually, this is a very good way also. I appreciated Professor Mahapatra's gesture. He presented very well. Contents are very good. and he thought in a attendee's viewpoint what can be a doubt, what can be a frequently asked question, and he has answered that. And from the chat box also, he has taken almost all question and answered. That made the work very simple. That's like a real teacher, devoted, committed, and understanding teacher, I'll tell. Thank you, sir, for the gesture. And if possible, you send your FAQs to Dr. Shakti.
Send it. Don't send it. Don't do it.
I thank all the presenters, Dr. Shampad, Dr. Shakti, and Dr. Ashok. They've done a good work, real life cases they've taken from Ashwini, Sham, and Keems. And I thank Professor Mahapatra for that nice talk on the radiology, because it's very difficult to cover, and many don't have such wide exposure, telling from the brief basic generation of the shadow to the interpretation of the shadow and correlation clinically. And we have taken good number of questions. So I thank panel, Professor Niveta Pani, Professor M.R. Patnaik, sir, Professor Prashant Raghav Mahapatra, Dr. Shamir Shahu, and Dr. Narayan Mishra also joined, and I salute his interest that he gives so much of time to get updated academically at this age and at this juncture. That shows his academic commitment. So I invite Professor.
So age is not a factor.
So age is not
your
a,
attitude, attitude to learn and tell. Give the share the knowledge.
Yeah.
What you have learned.
I'm not old.
Yeah, that's right.
What I'm saying is, you look very young, but post retirement also you have not left the habit of cultivating the academics. That's a real spirit, and I invite you for the next session, sir, as a panelist. Next Wednesday we are coming. We have a presentation by Dr. Sangeet Saboo regarding what goes wrong in non-COVID hospitals. So he is at non-COVID hospital, and he has very closely watched why non-COVID setups are getting more and more patients, and what infection prevention control we can. Issue Dr. Samit Shah will be presenting. Along with that, we have very interesting input from Dr. Manas from Aditya Ashwini. He also will take up more cases from different institutions.
I'll be there.
Next Wednesday, I invite all of you to be there, and Professor Mishra to join us as a panel, and all our panelists are welcome to be there in the next panel. So I thank the presenters, Dr. Ashok, Dr. Shakti, Dr. present the all the panelists, Professor Patnaik, Professor Pani, Professor Mahapatra, and also Dr. Mishra. And thank you everyone. It is a very successful academic session by Department of Health and Family Welfare, Government of Odisha. Will keep it on so long the pandemic is on. We will take up all your questions, and all relevant important topics we'll be doing. We have come to once weekly presentation now, so please watch in more numbers. I thank all the attendees for their attendance, and next Wednesday, that is on 16th of September, we are coming with this topic and cases. Please be with us. Thank you all. Thank you all.
Thank you.
Thank you.
And it was a really informative and interactive session. Thank you, panels. Thank you, presenters, and thank you, attendees, everyone, on behalf of us.